Good afternoon, everybody. Welcome to today's meeting. This is a meeting of the Health Overview and Scrutiny Committee of the County Council. I'd like to remind everyone present that this meeting will be broadcast live, and there's a wonderful picture over there of us all, and be available for viewing not just now live, but also after the meeting. Can everyone remember to please switch their microphone on when speaking and turn it off when finished speaking? That's mainly me that's made to, I think. And also mobile phones, if you can put them onto silent or turn them off completely, please. Right, the item 1 is the minutes of the meeting we held on the 11th of September. I propose the minutes of the meeting held on the 11th of September are taken as read, confirmed. Everyone agree? Thank you very much. Later, page. Question time. I've not received any questions from the public. Questions asked by members under Standing Orders 7.3 and 7.5. I've not received any questions from members. Item 4, to advise of any other items which the Chairman decided not to take as urgent. I've not been told of any other items. Declarations of interest. Any members have any interest they wish to declare? No, thank you very much. Declarations of the party whip. Do any members have any declarations of the whip? Thank you very much. Presentation of petitions under Standing Order 36. I've not received any petitions. So we move on to the first item, therefore, that we're discussing today, which is the primary care strategy. This is agenda item 8, pages 11 onwards. Primary care strategy 2019 to 2034. Gosh. And the development of primary care networks in Leicestershire. So I welcome Tim Sachs, the Chief Operating Officer for East Leicestershire Rutland CCG. Thank you, Tim.
Thank you, Chair. I'm obviously not talking about air quality. I haven't put together a presentation. So I was asked to bring along a copy of the most recent primary care strategy, which is a document that NHS England have asked us to put together. This is a Leicester, Leicestershire and Rutland document based on the fact that for the last 3 years I've been overseeing primary care across the system, and they requested a short, punchy and to the point document which illustrated the key areas we're expected to focus on. As you will notice, it is not detailed, it is not an implementation plan, and isn't really a particularly wonderfully public-facing document, which I recognise. The aim of this was we were given a 5-week timescale by NHS England to pull this together. So what we decided to do was try and pull together the key strands, but more to the point within there is what are our key ambitions, and those are the more important parts, which are how are we going to develop the system, particularly primary care networks, which I'll come on to briefly in a moment, to enable us to try and manage the key issues, concerns in relation to resilience, in relation to access, in relation to health outcomes that we have within general practice, and also the vast variation we have in general practice across Leicester, Leicestershire and Rutland. Just to pinpoint one point within the document, it shows that if you are a resident in Leicester City, there are 0.41 GPs per 1,000 population as opposed to 0.53 in East Leicestershire and Rutland and 0.51 in West Leicestershire, against a 0.58 per 1,000, which is what NHS England would like us to have. So there are really large differences, and one of the key points here is how do we look at doing something different with that. Which then leads us on to primary care networks, which is a fundamental basis of the new integrated care system. So although I'll be careful not to try and define what an integrated care system is for fear of creating and stimulating a debate which we may not have time for. One thing we know is that the move towards general practice working together is fundamentally part of the national strategy. The primary care network directly enhanced service, which is the first joint contract between GP practices, was introduced on the 15th of May, and we had from the 1st of July to get practices coming together to sign contracts of how they will deliver services. Now with this comes significant funding, but also significant expectations, and there will be money available for new staff roles such as physiotherapists, such as pharmacists, such as social prescribers, physicians associates, and paramedics to support the overall workforce. which is incredibly positive, although I'm sure you'll all agree these individual clinical staff don't grow on trees, and one of our biggest challenges is to make sure we have that workforce available. Within there's a focus on 7 key areas: access, managing population health, mental health, long-term conditions and complex patients, all the areas that really I'm sure you and your constituents mention to you on a regular basis. NHS England have very clearly understood that. So this is a really big change, and the fact that we have all of our practices sign up to primary care networks, the fact that they are starting to genuinely work together, although it's the very start of a very long journey. This is a very different way of doing things for practices, and one of the big elements that we are working on at the moment, and we're bringing all the clinical directors of the primary care networks together for our second forum on Thursday, is the support and development for them. We're very lucky NHS England are funding their development, but there's a lot of time needed on their own leadership, their own organisational development, but particularly what their vision is, and not just their internal vision, but then sharing that with the population that they serve in each of their primary care networks. So over the next 6 to 9 months, it's that element of working with the public, working with their patients, explaining what it means, but trying not to, what's the best way of putting it? It's not a monumental shift. It'll be an incremental change. And I think it's really important that people have to go on a journey together, because this has to be about, if services are going to change, it's working together on it. It's co-designing those. It's taking patients' views into consideration. Because otherwise, actually, it won't form the basis of the new system, which is about co-designing things and doing things very differently. So what I've included in here is the maps, because that hadn't been published before, and I think it's very useful for people to understand, particularly for their own areas. You find in most cases it seems very intuitive, particularly in the county. There are some geographical areas in the city which seem less intuitive, yet because of the geography and the small nature of Leicester City, actually it makes sense in many ways. So really that's just a very brief overview. There's a lot in the document, but I thought it'd probably be better to open up to key questions, because when it comes to primary care, I'm sure there are always many that people specifically want to answer. So I will hand it back, Chair. Thank you.
Thanks very much, Tim. I'm glad you opened up with the remarks you did about the type and style of the document, because that has come up. Yes, Sarah.
I'll start, Chair, thank you. I'd agree with your comment about the style of the document. It's we have to look at this from the point of view of the public, and the public would look at this and say, so what? It takes me 3 weeks to get an appointment at my GP's, this doesn't help. I mean, I'd say it's out of date, because it's got a 20th of June revision on it, and it's all under motherhood and apple pie. I hope this isn't what you submitted to the government, because on page 77 it's factually inaccurate, because Two Shires Medical Practice actually has a practice in Market Harborough. You've carefully drawn the line around it. People like my dad who go to the leisure centre will be most upset to find his medical centre isn't in the list. And I've been on about this before, and I'll go on about it again, broken record. It says in here at the beginning it's got to be contiguous with county boundaries, and loads of these aren't. There's overspill into Northamptonshire, there's overspill into Rutland, there's overspill into the city from the county. And I think at some stage the NHS corporately needs to say to these doctors' surgeries, stop doing it. You can't, be wandering off across here. I mean, my area, we're in 2 primary care networks, and frankly, I think that's mad. And everybody I speak to say it's not how it's supposed to be. And there's a couple of other places in the county that occurs. I particularly know my own area, obviously. So I think it's a step forward. But, when I hear instead from people it takes weeks and weeks and weeks to get an appointment, I'm sort of hoping it'll happen sooner rather than later. Thank you, Chair.
I'm not sure it's a specific question, but a number of points. You're absolutely right. The document is a little bit motherhood and apple pie. It's a very high-level area of the key areas that we need to focus on and actually do something specifically about. And ultimately, without the workforce, none of it's going to happen anyway. The key ambitions are absolutely right: to provide improved outcomes, to provide improved access, to support patients to get the services they need closer to home. Those are the key elements that we have. In relation to how the primary care networks were formed, the rules were quite loose in that sense. And the fact that, yes, you have 2 practices in Market Harborough, although one of them is a branch of Kibworth, and they're not in the same primary care network. Okay. It doesn't mean that they shouldn't still be working together, provide services, particularly in St Luke's Treatment Centre. And our practice boundaries do go over into Northamptonshire, and they do go over into Warwickshire and every other county that surrounds. But that's how boundaries work. We shouldn't just be working, as best we can. If a practice boundary does that, then we have to work with it. But it's just making sure we then work with the other areas. I mean, our second, in East Leicestershire and Rutland, for example, our second highest activity rate after UHL is at Kettering. So actually that's a big move towards Northamptonshire. So I agree with many of the points you've made, Dr. Hill.
Ted.
I was looking at page 15 where there's a quote from C. Ham, 2014. And this lady or gentleman has written a paper, Reforming the NHS from Within. And given that this is a generic template, but that this obviously applies in our case to Leicester, Leicestershire and Rutland, I was thinking it would have been appropriate, certainly in the next draft, to remove statements like this out and instead replace them with quotations from staff and patients from within the county to make it more Leicestershire-centric. Because that, for example, is quite a generic statement, and that could apply anywhere in the country. So that's, I think, how you could localise it more. And because you see, I noticed that you'd said at one point about asking, what is your vision? What do the patients want? And there's an opportunity there to insert boxes where you could say, well, person X said this, I want this for my family, or Dr. X said this, I want to see, this is my vision for the practice. And the second, this is a question, is when would a summary document be produced for the public and patients, and almost even in a form of a leaflet, like a sort of a three-sided leaflet to be given, that could be left in surgeries for the public to feel that there's more investment for them in what is being planned that will shape obviously their care.
Thank you very much for those comments. Just like to add, if you do look through the whole document, there are 3 separate local quotes, one from Healthwatch Rutland, one from a GP, and one from a stakeholder. So there are other local statements as well. But as you said, it's a relatively generic document in many ways. In relation to your second point, we did produce and have produced some local leaflets which show the boundaries of the primary care networks and what they are and what they do. But part of our significant planning with all of our primary care networks is that each of the practices within those is expected to link in with their patient representative groups, with local stakeholders, with patients, to start this dialogue and this discussion about where they're going. Now, all of the bits within the strategy itself, as you said, going back to Dr. Hill's comment, are quite high level and a little motherhood and apple pie. They are all key areas we're working on. But the key point from the local engagement, and it's the prerequisite for primary care networks and practices to be linking in with members of the public, is to have that joint dialogue about what are we going to do, how are we going to do it, how are we going to support you, how do we work together by asking you what the key asks are, and trying to develop it together. So this was never intended to go out to the public, but the joint work together, and we will support them with public-facing documentation and leaflets, which will then support people to understand what's happening with primary care. But if I just go back to Dr. Hill's comment, the first question will be I need to see somebody. That's the first point. Now, actually, part of it is how do we solve the key problems of access, as well as how this supports that to happen, which are the questions that people specifically have.
Yeah. And for clarification, because obviously this committee is screened on the internet. Could we be more specific what we mean? Because the meeting has slipped rather into metaphor, things like apple pie and motherhood. What exactly do we mean by that? You know, for clarity.
Apologies. Yes, I will. Was quoting one of your colleagues. What we specifically mean by this is that the document is setting out the key areas which we believe are absolutely crucial. It's not overly ambitious, I think is probably the best way of describing that. We know we have issues with workforce, we need to manage them. We know we need to make sure that primary care networks and primary care are absolutely integral to the way the system works. We need to ensure there is the right money, the right staffing, the right estates, the right IT to enable that to happen. These are all key priorities and ambitions which we need to meet, and at the end of each chapter our future ambitions are listed on purpose, because that's how we will hold ourselves to account and should be held to account for how we deliver that. So those are the specifics that we're putting on there, and that's really what I mean by that, Councillor.
Yeah, and finally yes, I have spotted those more localised comments, so thank you, and my apologies that I hadn't picked them up in the first sweep of the document.
Michael, I think you're next.
Thank you, Chair. I mean, firstly, just wanted to offer comment about kind of Health Watch involvement in kind of what's happening around the primary care networks. Of our chair, Harsh Kutech, has been involved in the primary care board that is kind of overseeing things from a strategic perspective. Myself, I've been involved in the more kind of operational primary care kind of review, and I think that's really beneficial given what this is meant to represent, and as everyone's been saying, that this is fundamentally about how it's going to improve services for patients, and I know Tim's kind of said on a number of occasions that, you know, that is a fundamental to kind of what this is happening. I think the something that I know I've said this before to Tim, but just for the sake of this meeting, just really want to kind of raise the point that I think there's a desperate need to make sure that this is set into context about what's happening with health and care as a system, and I'm not going to mention the phrase, but that's what's missing, I think, from a lot of public discussions about that. This is something that needs to happen, and I know there's a lot of pressure on the local NHS systems from the central NHS body, trying to kind of force things to happen, maybe at a pace that the actual primary care networks aren't ready for. So I've seen kind of Tim and his team kind of trying to act as a bit of a cushion to try and make sure that things are happening at a rate that is manageable. But from the public, they need to understand why these changes are happening, because there's some of the feedback that we get is that the people are just seeing it as another waste of money and another bureaucratic change to a system. And I think there's also a question around how much does the general public really care about primary care networks, as in what they are, who they are run by, and how they're going to operate within the operational kind of hierarchy of the NHS systems. It's very much about whether it means that they've got more access to their GP or the relevant clinician that they will get access to. But I think my kind of main point is just about trying to make sure that this, in the communications and the marketing, if you will, that it's done with the larger context about how it fits into the UHL reconfiguration, how it fits to the larger integration of health and care services, so people can appreciate and understand how it fits into the whole thing.
Thank you, Michael, and again, let's want to put our thanks to yourself and your colleagues for your support with this. It's very helpful to have you as a critical friend involved with it to make sure that we actually try and get this as right as we can. And you make a very valid point. A primary care network nationally is seen as these functioning bodies which are already delivering change in care. They're not. In many cases, they are paper organisations whereby they have signed something to say we're going to work together, and now they're trying to work out what that will mean. Next year is the real change, where they have to start delivering different services for patients, and they're planning on how they do that. But I think what's very important is the opportunity for primary care networks is there, but it's going to take time for services to change, for new staff to come in. The money is up until 2024, so it's a 5-year programme, and I don't think people will initially see change in in the short term. But as things are looking at being done differently, and if practices are working together and delivering care for their patients differently, and that might have an impact, that's where the conversation has to happen, which is, what does it mean for you and your family on the ground? Because if we don't do it from that basis, it's going to be lost in the, what's this bureaucratic change? Now, fundamentally, it's not meant to be. It is forcing practices to work together, many of whom were doing so anyway. But the impact has to be, what does it mean for you and your family, and how can we work together to make sure that we are supporting you to get better care? Because if we lose that message, then actually it will have lost it entirely.
David.
Chairman, could I ask you to look at pages 94 and 95? This is the Hinckley area. The Hinckley area surgeries. Well, yes. First of all, I hope that the Hinckley Central one, which contains my surgery, doesn't look after 638,000 people. It sometimes feels like that when you're trying to get an appointment.
I actually thought that time, but it had been raised in the address. Yes, I
Right.
need to make sure that changes.
Okay.
That would be a very large piece here.
Yes. And the maps seem to show sort of 50 shades of grey to me. I take it that these maps were coloured at one point, and I find it very hard to understand the various squiggles. It is important to try to understand this, and if could I please be supplied with coloured maps or some explanation as to what these
Yes, of course.
These lines actually mean?
In answer to the coloured maps, no, I'm afraid. This comes from a national centralised NHS system. They are actually shades of purple. Rather than grey, but of course we don't want to waste money by using colour printers. That would be waste of resources. However, the shades of purple and mauve are very fetching, but actually it's still quite hard to recognise the overlap of the boundaries. It is. It gives you the wider overview, but it is quite hard to do it. The only way of overlaying that would be with individual practice boundaries, and then using an old OHP to go over it, which we couldn't do. But thank you for recognising that, and I do see your point on that. Thank you.
David, you should have actually had all this lot as an email. We had coloured maps, purple, I admit. Yeah, about 2 or 3 weeks ago. Yeah. Amanda.
Hi, Tim. You've obviously come to the Scrutiny Committee before with regards to the role around increasing doctor numbers across the patch, and that's something you've been working on for a little while. I think one of the things that I have always been concerned about, and linking into Dr. Hill's point around capacity and what people see on the ground. One of the things that worries me a little bit is we're just creating a new box to still have limited capacity. How confident are you that this change from individual GP surgeries to groups of GP services will increase our GP capacity as such that we get to the 0.58 or wherever Leicester should be? And I recognise that's a national average, so it could be less, it could be more. How confident are you that we will start to see an improvement in capacity? And I suppose the other side of that is knowing what we know with regards to other areas that are increasing numbers, such as the ambulance service. And there's an area where we're trying to grow lots of new medical staff. Where do you see those individuals coming from, and how confident are you that we can reach some of these primary care networks' true aims, which is around physiotherapy, pharmacists within the practice, etc., etc. So I'd be really interested in that.
Thank you for that question. So, first and foremost, let's look at GP numbers themselves. Unfortunately, in the last year, we've had a 3.4% drop in GP sessions in Leicester, Leicestershire and Rutland. We know exactly why. GPs are doing, we've got the same number of GPs, but doing less. People are doing fewer sessions. That is multifaceted. Part of it is due to the pressure of the workload. A significant proportion of that is pension related. I heard of a GP recently who had a £140,000 tax bill, which therefore impacts on people's wish to work further. And we've all heard that in the press recently, and I know NHS England have done a consultation about how they can manage that, but it has had a direct impact. So there are some issues, and actually we think, ironically, 3.4% drop isn't bad in comparison to national, but you have to benchmark yourself in a number of ways. There have been some successes. We've had recruitment of 16 new GPs who have come in through the international recruitment campaign, and there are a further 16 which we should have by next year. I'm not going to mention any form of political impact from various potential policies, but they are completely, all of that is irrelevant. They are all being given opportunities to work here. So there are positives in that sense. There is a clear programme for recruitment and retention. There is funding to support recruitment and retention, and I think the change in the pension terms should have a positive impact, which is very helpful. However, we still need to make Leicester and Rutland a place that people want to come and work. And I think from the GP number perspective, well-functioned, well-supported, well-established and funded primary care networks makes it a good place to come and work. Because actually where the benefits come is from joint working and resilience, whereby if you work together, you support each other. Sickness happens if you can cover it from another practice, for example. If you do joint clinics, then you can gain capacity and skills. There are many benefits, but it's going to take time for those to be realised. And actually, if you were to bring things together, the negative of that might be that patients are asked to travel further. So therefore, that's why this has to be done jointly. The irony of this is that the additional money going into the 2.4 billion going into primary care networks, none of that money is put aside. In effect, none of the money is there to employ either GPs or nurses. In fact, it's only to employ other staff or to develop. And it's been made absolutely clear that this is not GP or nurse recruitment. So it then kind of moves on to that point of, if we are looking at new roles, where are they going to come from and how are we going to work as a system? And we've already worked quite strongly on that. And I'll give you an example. Working very closely with EMAS on the employment of paramedics for primary care networks. And they are very keen that we do this together. And we agree that if you have a pool of highly trained paramedics who are both working as an emergency service as well as working in general practice, they have their networks, they keep their continuing professional development, they can be employed by EMAS, which is one of the things that actually primary care networks are most concerned about, is the employment element. The funding can be pooled and we can therefore have more people. So rather than being 25 paramedics, you could have 40 paramedics who are working through a rotation, they are gaining those skills, and therefore there is a pool of people. And actually, by looking at it from a system perspective, I think that can add real value. We're looking at exactly the same thing with pharmacists, that the proposal that we have is that the newly qualified pharmacists will come through in January. And we're looking at proposing a training and development program whereby they will be jointly employed or possibly employed by UHL. They will work across primary care, community service, community pharmacy, LPT, UHL, but they will have a program and we can develop them. They will then be able to gain those experiences so we can grow our own, and therefore there is a recruitment pathway for them. Because at the moment, primary care networks trying to employ pharmacists, it's become a real seller's market, and some of the salaries being asked are interesting, significantly higher than you would expect. And actually, the funding that the PCNs are getting for those pharmacists won't even cover half the salary in some cases. So we're trying to find a program that will work. We're doing exactly the same thing with physicians associates in UHL and LPT UHL in relation to physiotherapists. So having a system-wide approach and doing it that actually supports people, that then encourages people, if they see a development pathway and the place where people really care about these staff, we hope that people will train here and then stay here. As I think I may have said in this committee before, we lose a significant proportion of our GP trainees who use Leicestershire as clearing. I think it's similar to the university. The university is, I think Leicester University is the most popular second choice university in the country. I think for vocational training, Leicestershire is one of the most popular places to come for people who can't get in London. So they come for 3 years and then they go again. But we're trying to make sure that more stay, because primary care networks and the way that we develop and train people is a system that they want to work in. So the aim of it is to actually make it attractive by doing it properly. And the networks are quite keen on us looking at it that way. So I hope I've answered your question as best I can. It is difficult. But if we work very closely, I think we've got a really good opportunity to make it better. Thank you.
Very much. I've got a couple of points. One of the areas, clearly, I mean, you've got it on the page 13 of the actual document, page 27 of our papers, about the key system challenges. And clearly, increased demand, how we provide care, workforce, finance, estate. Estate is clearly going to be critical. And a strategy for that, we look forward to seeing that when eventually you come up with that side of it as well, because I think that's going to be important. And the area that I particularly was going to focus on today, but in fact others have sort of half done it anyway, and that's particularly access, because as Sarah says, I mean, as you know, in my particular practice, we've had 2 practices merge. The access has got demonstrably way worse. And people are saying, oh, it must be down to this flipping PCN thing. Well, of course, it's nothing to do with that at all. But it is interesting how people's perception and what they hear in the news and what they see on the television and so on, and they instantly add 2 and 2 and make 17. And I think somehow this, I think as Ted said, we need something that's much more public related. And obviously, I understand why this is the form it is, but I think we do need something which explains to people a little bit more just what is going on and where there may well be some little bumps along the way, but at the end of the day, what we're all looking for is a far better health system. Yeah.
And I couldn't agree more. Just a note on the estate. Over the last 2 months or so, we have been doing a full detailed review of all 181 primary care buildings in LLR. That 6-facet survey is being pulled together. And within there, we will have an understanding of the state of the buildings, the utilisation, the capacity available. These will all be mapped by primary care network. They're also mapped alongside the plans across each of the councils, district council, unitary authorities on housing development, so seeing where we understand where the growth is going to be up to 2036 as best we can. So therefore, as part of that then, with each of these reports, and we will, January, I believe, we will be having that fully there to publish, which we, of course, will be very happy to bring here. Will then show us where we have the real gaps and the opportunities, because we very often hear we need more space, we haven't got space for people, but then you look at the utilisation, you look at how it's managed and how things are done, and the capacity across a primary care network, it goes back to the point of how they should work better together that Amanda brought up, which is actually working together, utilising buildings. Even heard an example of 2 practices very close to each other who said, actually, your facility isn't very good, our facility is much better. What we could do is put all of our admin, back office function, all of that in one building and use the other one for clinical, and we could change it to a whole clinical building, which would give us an extra 6 clinical rooms, for example. Now that requires some funding to enable it, but part of the planning would be, well, what potential Section 106 money is coming forward, what could we consider, and what's the feasibility of that to make it work? But this review will help us to do that. The second question is the most fundamental question that everyone asks, is access and what can you expect? And as everyone here will be aware, there are no standards on access within the contract. The only standard on access is meeting the reasonable needs of patients, which, to be honest, is pretty unhelpful. I think I've mentioned at this committee before that demand has doubled over the last 20 years for appointments. Part of that is the way the system works, as in recalls for long-term condition reviews, but also demand and demographic need. But there is an expectation that you get seen if you're urgently unwell. There is an expectation that you don't have to wait for a very long time on the phone. And often those expectations aren't met. And it is something that it has to be fundamental. Our new chief executive of the 3 CCGs, Andy Williams, started on Monday, and in pre-meetings over the last few weeks, I've heard him mention the word access regarding primary care more than pretty much anything else he has said. It is fundamental to him, and that all of the work that we do has to ensure that we have the appropriate access. Now, this may not be with your own practice, it may be with one of the Leicester City hubs, it may be one of the urgent care centres or evening and weekend services, but they have to be joined up. The IT has to enable people to be booked across both. and ensuring people know where to go appropriately, because without that, the question of access will continue. So it is absolutely front and centre of all of the work that we're doing, but the variation is still too great.
Thank you very much, Tim. Yeah, I'm actually logging in at the moment into my NHS app, of course, just to demonstrate how dreadfully difficult it is to get appointments at the moment. Actually, the worst of it is, one of the first questions I get asked is not where or who, but what type. And it's all related to very strange wording, which I'm sure I actually understand because it mentions the word System 1 in it several times. But the normal man in the street would have not a clue. It's quite unfriendly, and I shall be mentioning it when I next reply to NHS app people, that you need to make this a bit more public-centred. But it just shows how difficult it is for people if they want. Lee, you wanted to...
Yeah, thank you, Chair. It was just a couple of observations and a compliment, really. Primary care networks were designed to improve access, and I think what you have in front of you is a starting point. I think it will evolve. I think changes will occur. I think primary care networks may merge, they may grow, they may shrink, but I think that is an evolution process, and I think it will solve the big word, which is access. Tim spoke about cross-boundary working, and obviously it's interesting. I was at George Eliot Hospital yesterday, which is obviously North Warwick's, and he said that 30% of his patients there are from Leicester and Leicestershire, and that's a huge amount of cross-border. And if you look at that, that's the type of works that we've got to go through. But interestingly enough, North Warwickshire aren't where we are, and compliments were certainly paid to Tim and his colleagues for actually having this strategy in place, and also the primary care network set up, because that hasn't happened across the country. So we are leading the way, and I think sooner it sort of beds in. Looking forward to that. So thank you.
One point on there. If you go to Rutland, for example, 80% of patients for urgent care are going, not for emergency admissions, are going to Peterborough, for example. The same Market Harbour, going about half going down to Kettering. Our borders are not, there aren't walls. Unfortunately, the system sets it up that we have single documents. One of the big elements with the new system, how we're working together, is making sure that we step over those to make sure that we've got that integration across the patch.
Tom.
Yeah, you talked about pharmacies. Is it envisaged as each primary care network will have its own pharmacy?
Pharmacies are a real opportunity. And I meet regularly with their local pharmacy committee. They have a new contract which started, I think it starts on the 28th of November, whereby all pharmacies are going to be paid to do minor ailments appointments. And whereas before it was a commissioned service from NHS, from clinical commissioning groups, it's now directly as part of their contract. They are very, very keen that that forms part of the pathway. Not just because it brings the money in, but actually it really supports. And the IT is being set up that practices will be able to book patients into pharmacy, that urgent care will be able to book patients into pharmacy, and vice versa. Pharmacy can book back into practice if they see someone who is more urgently unwell who needs seeing. So that's a real opportunity. The LPC will be presenting at our January Clinical Director Forum because they've got an offer. How do we work with primary care networks? And what they want is a really close relationship that actually has that kind of symbiosis between it, that actually patients can flow between. They can share data. There's even talk, you mentioned System 1, of having portals which enable them to actually see patients' records. So we've got the whole IG element, the information governance element we have to manage. But I think the pharmacies working closely and having a close relationship within each of their primary care networks is absolutely key. It's unfortunate that within the new NHS England reorganisation that the pharmacy contracts have remained with NHSE centrally. We were very much hoping they would come to clinical commissioning groups because the real connection between pharmacy and general practice, slightly more than with dental and optometry, we really see the benefits of that. But actually the relationship is good, and the pharmacy committee are really pushing the agenda of close working, and we very much welcome that.
That's really good news, actually. I think we've got something really positive there we've learned today as well. Thank you very much, Tim. As you said at the start, I mean, this is a process you're having to go through, and fair enough, we accept that. And we look forward to, obviously, future reports as you move through the raid and get back to us in the future. Thanks very much indeed. Oh, Brenda, sorry. Oh.
No,
Sandra.
it's my fault. I think, to be honest, not my head hurts. That's wrong. I'm listening to so many facets of this, so many different avenues. You've just brought in there a different one with the pharmacies and the mild ailments. How is all this going to be scrutinised? Because to scrutinise it as a whole package is going to be nigh impossible. So, and it's obviously going to come back here, but it's the whole thing is impossible to scrutinise as a whole thing. So I wondered whether you'd put any mind to how we can scrutinise this effectively and not as a whole, but separate it and to see how it works. Because obviously it's a 5-year plan. Do we let it run for the 5 years and then scrutinise it in depth, or do we scrutinise it after 6 months, after a year? Do we put it all into sections and say, right, we'll go into depth in this one? So that is my concern, scrutinising it.
It's a very, very valid point. So one thing you may or may not be aware of, but as of 6 o'clock this evening, a management of change process happens where all of the current exec directors across the 3 CCGs are put at risk. So it's a happy Wednesday for some of us, where a new structure has been put forward and proposed, which Andy Williams wants in place if internally appointed by January. Now, within there, I can't say anything because it's not quite out there yet. But what I will say is, within the roles are across the whole system, and they're across multiple pathways. So I currently am lead across the system for primary care and medicines management, and that is my area, hence why I'm coming here. The new roles will be broader, and therefore, rather than having lots of separate people to come and talk to you, you should have an individual who is able to give you a much broader perspective on all of the different areas and how they all fit in. So that may help in that you have someone who has that broader knowledge, but actually it may not help in other ways because they're coming to talk about everything. So I think I see exactly where you're coming from. That will be helpful in that you don't have 3 people doing the same jobs or doing similar jobs or not doing system ones. But with the primary care strategy and how we're looking at developing primary care networks and the relationship really with community services, I think we need to come and regularly report to you on our progress. Whenever I'm invited, I'm always happy to attend. And as long as I'm still in a role, then I will be happy to come. And we can talk, maybe have a broader element. And I think what would be helpful is maybe if we could agree mutually a programme over the next year, maybe I don't know how often you'd like me to come or an individual to come, and we can set a programme of the areas that you'd like to scrutinise. And put that together so that you are clear on what areas and we can look at the progress. I'm really happy to jointly put that together, obviously agreed by the committee, that you feel that you're getting a full understanding, because really this is very high level and it's quite hard to scrutinise something that basically says this is our aims. The question is, how have we delivered, which is what you need to know. So really happy we can start bringing reports which give more detail on that.
Well, I certainly, Chair, would appreciate that. And I don't know whether the committee's qualified to identify the particular areas. So I think probably you would be, or your colleagues would be, in a better position to identify those areas that can be honed down to.
Spokesmen and officers do meet to have an agenda planning considerably in advance of these meetings, and I think now, Rose was nodding, she's written it down. So we do need to get, you're quite right. I mean, I was looking at the key system challenges, all 5 of them. I thought each one of those could take a day. So we need to do something to break it down. I agree with you. Okay. No one else? Nope. Think you'll go this time. Thanks very much, Tim.
Thank you, Chair. I'll stay here if that's all right. I know it's customary for presenters to go over there, but I'm lazy. Well, I'll try if you want me to, but it's probably not going to be as good as Mike's would be. And just brought the report to the Commission because this is quite a big piece of work that Health Watch in Leicester, Leicestershire and Rutland have done jointly, and it was done to be able to support the refresh of the long-term plan. Not the sustainability and transformation plan that's kind of being reviewed and refreshed in light of the NHS long-term plan and various other shifts and changes that's happening with the NHS. We were commissioned by Health Watch England, by NHS England, to try to undertake quite a substantial piece of engagement work and try to talk to as many people as we can do, or as we could do, about what they want to get out of their, well, health and care services, if you look at it, but this does have a bit of an NHS focus. So the report is the findings from the work that we completed speaking to, I think it's just over about 600 people across Leicester, Leicestershire and Rutland. And it was kind of broken down into two approaches. The first one being asking people who don't have any pre-existing medical conditions about just what their experiences are and what their expectations are from health and care services. The second part of the work was about talking to those that already live with health conditions or long-term conditions as they're termed. And this then kind of broke down further into people that live with learning disabilities or with mental health issues. There was also kind of a broader long-term conditions kind of part of that, and that then led us to target community groups as well as organisations that we have a working relationship with that support people with these health conditions, and that was again because of their more regular interaction with health services. We felt it was we wanted to get their experiences as well as whether or not their expectations have been met with services. So without kind of I'm not going to go through the report in great detail. I think that would be a bit of a laborious task, but it's primarily a document for you as the statutory sector as well as the NHS services to get a bit of a sense check as to what people are thinking. And admittedly, it's not every person who lives within Leicester, Leicestershire and Rutland, but it does offer certainly an indication to people's experiences of services as well as what the services are offering to people at the minute. And some of the key messages that kind of came out of that, I think the first one is a broad stroke is about communication between patients and clinicians as well as internally within the services themselves, whether it be patient records between clinical commissioning groups or GPs and hospital services. But that was certainly a frustration. But the key communication between patients and the clinicians was about making sure that the patients felt that they were a part of the discussion, a part of the decision-making process. And the frustration is that even with the rhetoric of no decision about me without me or patient-centred care, whatever you want to call it, it's still something that I think patients feel more often than not that it's something that's done to them rather than with them. And that's certainly bears out in the previous report that came to the Commission around discharge, where patients, again, they don't feel as involved as they want to be. So that's certainly a kind of a strong message we're taking back to the partners and the where we kind of attend as patient representatives. When we look at the longer term conditions, there was of the different subset long-term conditions that we talked about, a consistent issue that came out is not enough understanding about the condition that people live with or what their reality is. And that was certainly a call out to clinicians to have that a better understanding, not an in-depth, but a better understanding of what it means to live with that condition and what the support might be more relevant to them. And just to kind of lastly touch on something that has come out not just as an issue that was more focused around in the county responses as well as Rutland, but is also being picked up by Health Watch England as a bit of a national issue, and that's the issue of patient transport or the implications of public transport on people being able to access care. And that was again something that very strongly came out when we were talking to people from kind of around less central in the county. and as I say, came out in a number of the reports that the local health watches have done, because this was replicated in every health watch that wanted to kind of access the support that was being offered. So there is a substantial amount of kind of national evidence that's now being reviewed by Health Watch England, and patient transport is one of the first issues that's been picked up by them. So I'll kind of open it for questions.
Jonathan.
Thank you very much, Chair. Michael, I just really wanted to get my head around, so in the opening paragraph you talk about the purpose of the report and talking about the fact that it's specifically related to people with long-term conditions, and I'm assuming that the access to those people as a result was through surgeries or through hospitals to actually access the right people. Can I this sort of...
Yeah, that was a very small avenue that we used, given the kind of, I suppose, the bread and butter of what we do as Health Watch. We have built up relationships with community groups as well as GP surgeries, hospitals, the voluntary sector who offer support for people who live with those conditions. And whilst it's a section of the work that was done, what we utilised was not only the relationships that we have built up over the years with either specialist community groups or the specialist voluntary sector organisations that support that specific community. We also kind of operated standalone workshop sessions that we kind of set up in the city and county as well as Rutland. We visited GP practices, outpatient clinics. We tried to take advantage of every opportunity that we would have and that we were aware of that would allow us the opportunity to firstly kind of talk to either the general public or people living with longer term conditions about the work that we're doing, and then offering them the opportunity to complete a survey.
Okay. I was really trying to understand the context of the report and some of the figures and the way it's presented. And my first reaction, having worked alongside market research companies, and one of the things about sample sizes and about making sure that you've got the right sort of split as far as demographics, etc., is concerned. And obviously, by the sounds of it, the subset that you're trying to sample is reasonably general, but actually quite specific about what the sort of information that you're trying to actually get back to be useful. I think more than anything else, when I read the report, it was just a slight concern that it was being presented as being a sort of piece of evidence, when I'm not entirely sure that the sampling that was actually shown in the report isn't something that I'd recognise as being consistent with general market research criteria. And as a result, it's trying to actually, I mean, I think it clearly has a great deal of value and worth, certainly from some of the feedback, individual comments that are made within the report. Some of the statistical analysis that are actually drawn, I feel slightly less enthusiastic about, given that it doesn't seem to actually have a statistical weight to the way that some of the sampling has been done.
I absolutely get your point. It's not a piece of market research, and I want to make that clear. I suppose the reality is that there was we myself and my team as kind of the local health watch, we did a lot of the field work. The statistical analysis was completed by our head of research, who is a part of the Engaging Communities Staffordshire organisation that holds our contract. And I think what we was trying to do is to try and kind of capture as many pieces of opinion or experiences as we can do, and then I have to be honest, I kind of then passed it on to then kind of do the analysis. I think if there is anything that you think is, we wouldn't want to be kind of trying to suggest that this is an absolutely and comprehensive piece of evidence, but it is about that kind of, these are the opinions that some people have expressed, and I think the breakdown is just to try and give a bit of a sense of the different parts of the community that we spoke to. But if there's anything in particular I think that we just need to be aware of, I'd be grateful for any feedback.
Maggie.
I think you've just completely answered my question, actually, because it, as you said, it's an indication of a service. And my questions were, how do you select the sampling? What are the difficulties of engagement? And how representative is it? I mean, I think people are willing to engage if they want to tell you something, you know, and you get the stories that they want to tell you. It's more difficult, really, to get a bigger, broader picture. So it's just my concern is over the sampling, as really Jonathan's has just covered. So a comment.
Thank you, and absolutely, I can appreciate the comment. I think the approach that we took was to, as I say, try to offer the opportunity and the chance to firstly kind of set the context of the work that we were doing. I'm very loath to kind of send a survey out and expect people to fill it out when you've not had a chance to talk to them about what you're trying to find out from them, so that you can kind of offer some kind of questions. And a lot of the communities, a lot of the community groups that we engaged with, it would have been foolish to just send the survey out. So there was quite a lot of actually having to change and to accommodate some of the community groups that we went to, because we went down with this set survey and wanted to ask them these very specific questions, and then as soon as you start talking, it goes out the window. And that's just the nature of community engagement, that when you start to talk about something as broad as what do you want from the NHS or what people's experiences are, you then just have to let that kind of conversation go. As far as the set sampling, it wasn't that we kind of went out with a set, we're going to get 1,500 people, and that then kind of breaks down into demography X, Y, and Z. Our remit is all communities, all ages across Leicester and Leicestershire. So we have to try and kind of allow that flexibility with whoever wants to kind of come back to us, and it was just about trying to set the net as far as we can.
Ted.
On the point of the statistical analysis, it's pretty much encapsulated what you're saying and the comments that have been made in point 1.3 on 111, because if you say survey data was quantitatively analysed, which of course is numerical, you're just gathering numbers and comparing the numbers. But then, of course, your second half of the sentence, and the focus groups, interviews and stories, were subject to thematic analysis. And, of course, thematic analysis is linked with qualitative, and that is your stories. So really, you've got a report of two halves there. You've got your quantitative and qualitative. Now, it's ironic, really, that actually, if this report is looking to garner some information about people's expectations of their health care, something very interesting has come out of this report, and you can virtually find it on pages 126 and 127, and it's entirely in two of the, and it goes back to the point I made to the doctor earlier on. It's actually in two local stories, because if you look at the person with mental health problems, that in the second paragraph on the large number, page 126, they were feeling worse at night. They didn't have anybody to talk to. They didn't know where they could go. And then, of course, you go to the person who's had a physical condition, a stroke, no additional support, general feeling that there's no follow-up care or care in the community. I feel I've been abandoned. These two things speak very much to not actually to the NHS, but that actually speaks to this wider issue of loneliness that we've got in British society now, because and please don't think I'm talking as if I'm someone that knows it all, but as someone who has come through the acute psychiatric system, I can tell you now that this is an incredibly common thing. So I would actually like to congratulate Healthwatch, because your piece of work has picked up an acute problem that exists in society. You have people not just with mental health conditions, but you have people with physical health conditions that are saying virtually the same thing, that I'm isolated, I've got no support. And really, at what point on this subjective scale does the NHS cease to, and this is a question asked in the third person, at what point does the NHS actually stop to have any jurisdiction and moral obligation to assist, and what point does the community, because the care could be incredible, but that person with mental health problems will still experience those problems in the evening, and the person that, unless there's an enormous increase in funding into the voluntary sector, people who have had a stroke will feel isolated in the community as well. So I'm congratulating you on raising these issues, but they are big issues that you've raised. So we can have all the qualitative and quantitative data, but these two things here have highlighted an absolutely critical, enormous problem.
Thank you. I really appreciate it. And I think this kind of comes back down to what underlies a lot of the work that I want us to be undertaking locally. There is a lot of market research organisations out there, and we've got 2-3 large universities on our doorstep that could kind of do what other academic kind of research you would ever choose to do. But we spend years building relationships with community groups, as well as trying to become an organisation where people can come and share their experiences. And nothing changes somebody's mind more effectively than an emotive story of somebody who's has that lived experience. In all of the meetings I go to of this nature, as well as from the other parts of the statutory sector, it's the reports that just tell you about 60% of the respondents said X, Y, and Z don't have as much impact as somebody who can stand in a room and say that this service had this impact on my life. So having that individual story is vital to kind of what we want to be sharing and what we want to be kind of facilitating as far as bringing to here, as well as other statutory meetings.
Yes, and leading on from that, and I think, Chair, as well, that there needs to be a point X that at the end of reading this report, this will happen, or this is the aspiration. And one of them is that this message, the conclusions of this, rather than the qualitative, the 42% of people said this, that these stories have to be promoted to the CCGs, but also to the voluntary sector and to the media, for the wider public to be aware that the surgeries, the health service can do as much as they can, but there's got to be a community engagement and a take-up, that we've got to move away from this, they will look after you and then you're on your own. This is a wholesome approach. People's mental health will improve when there's more engagement in the community, and people won't recover necessarily from a stroke, but they'll certainly, for example, the morbidity issues won't increase with their mental health deteriorating because they're so isolated.
Just as a bit of a kind of what is happening with regards to this, as I say, we did a lot of this work in conjunction with Sue Venables, who's the comms lead for the Better Care Together programme, so a lot of the stuff that's happening across Leicester, Leicestershire and Rutland. And it was, as I say, very much kind of pulled together to try to then make sure that those very examples are not only shared with the kind of senior responsible officers in charge of all the different work streams that's happening across the Better Care Together programme, but it's then kind of fed into and fundamentally kind of woven into the refresh that's happening. And this is, you know, this is also my kind of source of what people are saying when I'm then going out and being a patient representative at, say, for example, the primary care network meetings that I might attend, or the community services redesign stuff that's happening at the minute. So, and what I would kind of also ask is that if this is something that is relevant to you, that you use it as much as you can do. If you need anything more from myself, then please just let me know.
Yeah, thank you, Michael.
Yeah, no, thank you for that, Michael. It's very useful.
Hi. A couple of things, really. I mean, obviously, Jonathan's already brought up quite a bit in terms of the statistical elements of this. I think the only real comment in terms of the numbers surveyed is the condition survey for Leicester City patients, clients. It was really, really low, 21 out of the 600. It's really difficult to draw any conclusion, really, from, and particularly when you segregate the data down into several long-term conditions, it's maybe only one or two for each. I think that is a bit of a concern. The other thing, it's a bit of a bugbear of mine. Was there any reason, or is there any sort of work that can be done to aggregate the data by gender? In terms of, are different genders feeling a different experience in health services? You know, the data is here, and we've certainly collected it. Is there any statistical relevance to the service that our female population might get as opposed to a male, or those who don't define as either? I think that would be useful. And in terms of some of the conclusions and some of the comments and things that have been brought into this, I'd be really interested to understand, and where is this going to go? So, you know, summary of the findings of the focus group is on 4.6 for it's on page 149. It says one worthwhile suggestion is that the introduction of a park and ride scheme for Leicester City to the outskirts of Leicester hospitals. Where is that going to go, and how is that going to come back through the circle, so to speak? And the second point, sorry, this is on an earlier page on 145, and it is sort of referenced in terms of the numbers, but it says people in Leicestershire have to wait longer to get a diagnosis than those in Rutland and Leicester City. I'm not sure whether or not that, in terms of the data that sort of point has come from, is actually that people are waiting more in Leicestershire than those in Rutland and Leicester City, or the expectation is different. And I'd be really interested, obviously, Mike's team do sort of some work around statistics of how long people are waiting, of whether or not there is any geographical differences, and whether or not we could take that back through the circle, so to speak, to have a look at that. Because I'm not sure that is the conclusion that is drawn from the data, that people are waiting longer. It might be their expectation that they feel they're waiting longer, or that their expectations are higher.
Thank you. Yeah, I mean, with regards to the kind of the first point around the number of responses for the long-term conditions in Leicester City, it was much more of a struggle to try and get responses from Leicester City than Leicestershire, if I'm being honest. Now there was an element of some of the resources that we have available to us as a very small team, if I'm being honest, but also just it was a much trickier kind of ask to get people from Leicester City to respond. So I think we did face a little bit of difficulty there, but I absolutely take the point that you're making, and I think it's with regards to a lot of the responses in the survey, it's from the responses that we had, and I think if we had more money, more resource, then we would want to do a much bigger kind of piece of work around it. With regards to the looking at things from a male-female perspective, the one thing that I'm aware of that the analyst did do was highlight any kind of statistically significant differences between different kind of subsets of data, and one of them was male or female. So if there was a significant difference identified through the responses that we got, then that should be then kind of highlighted in there. And if there isn't, then there wasn't. But
Can I just come,
Sure.
just come back on that? I think the important thing, though, for us, if there is no statistical difference, is to say that we didn't find that there was any statistical difference between men and women in this area, or make a comment about it, because it does worry me a little bit. You know, I can only talk from, you know, what I experience, for example, at the school gates, but it's mainly mums that will be ringing up for children's GP appointments. If there is a child with a long-term condition, obviously that's a partnership in the family, but I think it'd be really interesting to understand from a carer's point of view, are the carers predominantly female, therefore, you know, the way they're feeling is different. I just think if it's not statistically relevant, the document should also say that.
I take your point. The difficulty is that we can't put everything that the report doesn't demonstrate, and I think I'm kind of more than happy to take it away, but we had to make a conscious effort to actually kind of strip out a lot of things that didn't represent any real difference between the different either sexuality groups or the demographic groups, because it would have been the report would have been about 4 times longer. But I absolutely kind of get your point about maybe a comment just at the beginning about that they would not represent a statistical significance if there's nothing reported. With regards to the kind of the park and ride, I think the report, the work that we do, it's not to come up with the solutions to problems. It's more often than not just to identify and to highlight that this is what patients and the public have told us is something they would want to be kind of looked at. And this is one of the reasons why kind of our work with Sue Venables is so important, because she's our main kind of route, as well as bringing the report to this group to then say, look, this is what we've been told. We are contracted to be a representative of the public, not to figure out how you can fix the problems the public has highlighted. So we would certainly kind of raise this to the relevant organisations that we think might be able to kind of offer some insight or some kind of options, and then if there is a potential opportunity to work further in it, we can do, but it's a difficult balancing act, so we can certainly take that away and just highlight it. And with regards to the kind of people waiting, again, I think the caveat is that from the responses that we had, it was very much the question asked about what people's waiting time was, so it's entirely possible it was down to their own perception. But we represent patient experience, not the operational reality of the waiting times within NHS services, and it's important to represent that if the way they felt doesn't necessarily replicate what was the reality, that's actually not as important as that's how they felt.
Brenda.
Thank you, Chair. I'm afraid I'm going to be probably critical, so there's no compliments here. Well, there's a lot of positives. You've gathered all this data, and my problem is parking it. Where's it going to go? And reading it, it's not going to go anywhere. It's going to go to local authorities, policymakers, and general public. And then in turn, readers will use the public's voice to guide them. But they've already got a public voice. They've given it to you as the representative of the public. And I think we're talking about perception of waiting times, but the perception of that person that's told you they're having a problem is that you will take that somewhere and sort it out for them. That's what, you know, if I go to somebody specifically to talk about an issue, a problem, it's like, because as a counsellor, if somebody comes to talk to me about an issue, then they expect me to sort it out. They'll talk to me and their perception is that I will sort it out. And that could be, and I should imagine that the people that spoke to you, the perception would be that that problem would go somewhere, and it looks to me as if it's not being parked anywhere. So I'm questioning the value of all of this data if it's not specifically collected to solve a problem. And again, with the last one, I think there's too much information there. I think it's just too generalised. You've got lots of conditions, health conditions. You've got different genders, you've got different ages, and sometimes I think that you've spread at your wings too far, and the data is diluted, and probably not much value from that. So I don't think there's a question there. I'm just finding it very hard to know the value of that whole questionnaire that you've done, and so I'm sorry about that.
Don't apologise at all. I think the points you make are valid. I think there is firstly a kind of an important differentiation between we capture and represent people's experiences, and we make it very clear we're not there to fix problems. We're not an advocacy service. That is a separate contract, and that is something that we signpost a lot of people to do. A lot of people too, and we get a lot of cross referrals around it. If we find ourselves in a situation where we can offer some kind of help and support and guidance, then absolutely we would always offer that. But the work was kind of done under the auspice of it being able to then represent what people's lived experiences are, not that it would then kind of lead to a specific fixing of one problem or another. But we make that very clear. That is not something that we have the resource, the reach, the capacity to do. That's why we have these conversations, to be able to then say to you as the councillors and the statutory sector, these are the issues, this is what needs fixing, not to then come up with the solutions. With regards to the kind of the benefit and the, I suppose, the relevance of doing what we do, I think there's a larger question here about, so why does the council do consultations? Because it's the same thing. You're asking people what their opinions are and what their experiences are, so that can be then taken away and built into the larger appreciation of understanding that, for example, the NHS would when they're looking at the operational review of a service. So they know what people's lived experiences are. They can see whether or not things might be able to shift and change, understanding that lived experience. It may change, it may not, but it allows a more informed decision to be made. And that's fundamentally what we want this to be. We want this to be a piece of information, a piece of evidence, a piece of opinion that allows those who are going to make those significant changes to then go, okay, I can now make a better, more informed decision about the decision in front of me.
If I could just come back on the fact that the council does do consultations, you're quite right about that, but we do consultations on specific things. We don't do consultations on a whole raft. So the questions are specific about one aspect. My point is that I think there's too much data here to come to a conclusion. So I think the data won't necessarily be parked in the right place, and the right people see that data. That is my concern.
Yeah, that's fair.
Ted?
So to move that on then, would it? What scope is there for you to take the information you've got, qualitative and quantitative, split them again, and do some more centralised pieces of work on them? So, for example, there was a story about somebody who had a heart attack, and they were still waiting for physiotherapy after about 6 months, and they felt they were vegetating at home, their words. And so maybe, as an example, to say, right, we will now do a piece of work where we will seek out people who have had heart attacks and see what their result, to see whether it's a similar pattern, or like Mrs. Hatt, we will focus a study on the city to maybe or on gender, age groups, to specify, to build on all the data.
Yeah, and that's something that we do on a yearly basis to look at. We have through reviewing the insight that we gather through work like this, as well as the kind of ongoing and pretty much constant engagement with members of the public through events, through drop-in clinics, through going to kind of different locations where we can talk to members of the public. We would then kind of set specific kind of certain work priorities, and would also kind of talk to kind of the directors of public health, the directors of adult social care, as well as children's services, the hospitals, the mental health services, primary care services, and I mean, as far as Councillor Seaton's point around the kind of remit being quite big, the remit for Health Watch is staggeringly broad. And very difficult to really kind of manage without trying to kind of pin it down. The work that this then represents was something that we kind of worked under a remit from NHS England, and we tried to kind of narrow it down a bit to, rather than the questions we're asking, it's who we're going to be asking, and that's how we tried to narrow it down. But the kind of the way that we try to prioritise the work that we're doing very much kind of draws on this as well as other things. So, for example, there was a report to the meeting last time about the experience of patients through discharge. That was a priority that identified. We've just finished a piece of work that's looking at what the experience is of patients between hospitals and primary care services when it comes to medication, because that's something that people have kind of have told us, and it's identified as being a potential issue. So to trying to kind of dig a bit deeper and get a better understanding. We're about to do some work around social prescribing, about what the general population's understanding or even awareness of social prescribing will be, and what they might be able to offer us some insight and some opinions that would then feed into Mike as well as Ivan at the City and various other stakeholders. As far as this kind of piece of work, we're kind of waiting to see what comes out or that's starting to emerge from the Health Watch England's review about some of the larger themes. So, for example, the patient transport, that's, again, something that has kind of identified that we might then want to focus on with our smaller work priorities in the next contract year, because we're going to be doing some work around access to community mental health services as well as lifestyle services and supported living for kind of through next year.
Michael, would it be fair to say that all this data is actually collated by NHS England from all over the country, which then directs them in the direction of travel which they want to provide health services throughout the country? Or is that just optimistic?
I don't know about the kind of the larger NHS England. I think that would probably be a very lofty and bit aspirational, but certainly kind of locally. We're kind of using this, as well as the other reports that we've generated and the other insight that we capture from the public, to then kind of work with the kind of people behind the scenes that are doing that kind of re-look at what they're going to do priority-wise, to then say, look, this is what patients face, this is what patients feel, and this is what patients hope they'll be able to kind of achieve. I would hope that NHS England do kind of take this as well as some of the other stuff that they do. You know, they've got NHS Citizen. There's so many kind of different little parts of patient engagement and patient experience that kind of try to pull it together. But whether or not that's done in any kind of meaningful way, I couldn't say.
Thank you, Michael. I mean, I certainly found the actually probably more than the actual raw numbers, but actually the comments, the particular bits that really hit me hard. I think some of the comments in here, I've been doing some work recently with some autistic people, and every one of these just leapt out at me, so many of the comments and so on. I think, thank you very much, Michael. I mean, you've had some comments. Hopefully that'll be helpful. And we look forward to your next report. Thanks very much. Move on to agenda item 10, which is a report of the West Leicestershire Clinical Commissioning Group, Hinckley Community Health Service Review. And I see we have Spencer here from West Leicestershire. Delighted to see you. And for once on one of these days, there's some actually what you call good news, I think, really, isn't there? I'll let you.
Thanks. Well, hopefully you see it as good news. I mean, we've had indifferent news, bad news, and then hopefully good news here. I'm assuming people have read the paper. It's fairly short. We've tried to keep it simple. I guess we'll see from the questions or comments as to whether or not we've managed that. I will just give a quick summary of, you know, people will be aware of the changes that we've been planning to make and working and engaging with the public since 2014 around. We had really good news about receiving capital funding to allow us to progress those plans, and we're into the detailed planning stage, but we've got a really long way to go on that before we can enact the whole scale plans that we're trying to do, and I think that's explained a little bit in paragraph 5 on page 160. Subsequent to receiving that good news, we've had the bad news that we needed to close the X-ray at short notice, and therefore we've been trying hard to secure funding to replace that and get that back up and running, because that is closed at the moment and patients are being diverted elsewhere. The reason that I need to consult with this body today is because we intend to make that one change that was part of the grander changes without consulting with the public. I think in of itself, it isn't a material change to service. It's essentially moving it from one building to another, which is actually attached. The reception area is in exactly the same place. You know, patients would sort of go in and turn right instead of going in and turning left. So that isn't normally something we would consult on. But we have needed to consider consultation because it was part of the bigger piece. So you know, we've taken legal advice within the CCG about whether we think it's appropriate to go out to consult. And I think we felt that we needed to consult with this body to get this body's support. I discussed this with the governing body within West Leicestershire yesterday, and they were very supportive, subject to OSC support, for us to not consult with the public, to almost separate it out into the bigger piece of work that we're going to do that's going to take several months, and the getting on with replacing the X-ray, but also relocating it into the logical place, which is the building that is essentially in a better condition of the two buildings that are adjacent to each other in the centre of Hinckley. So I'll take comments, but I particularly want a view from the committee that supports our direction of travel at the end, if possible.
Thank you very much, Spencer. Yes, we've had a input from Janice Richards, who's the county councillor for part of that area as well. And I'll read her comments out because I think it's very relevant. I'm in agreement with West Leicestershire CCG preferred course of action for patients within the Hinckley-Bosworth area to reinstate the X-ray machine into the new location at Hinckley Health Centre as quickly as possible. With the rapidly growing population in Hinckley and Bosworth area, improvements in healthcare are very much needed. I also feel as though the area has been left behind with improvements over the years. Hinckley Cottage Hospital has served the community for many years excellently, but you only have to look around to see that the hospital will need an enormous amount of investment to improve the building, but it would still, in my opinion, still not be fit to accommodate the modern technologies of today. However, we do need further facilities. I think it's essential that the X-ray be installed as quickly as possible so that local residents do not have to travel a considerable distance. It would also alleviate the pressure on other hospitals. So I think you've got a vote for it there. David.
Obviously, we all share the same view on this, and we do welcome everybody in the locality welcomes this report. Could I draw attention to paragraph 5? When you read that, this really shows you what a tortuous process we all have to go through in order to get any improvements made. And we're only at stage 2 now of a 4-stage process. I mean, I've been involved with this since about 2005, when, or possibly before then, when the proposition was put forward that the then community hospital should be extended. And we seem to spend years, literally years, on consultative events, or pre-consultative events, engagement events, which seem to go on forever, and bring us back to the first step. We all have to start again, but we keep doing it because the improvements to our local hospitals is so important. So we stick with it. So that's the first point. I think it's worth just noting that it is a dreadfully drawn out system to get anything done. Now the second point, the reinstating the X-ray service in Hinckley. Of course, everybody welcomes this, but I think it would have been appropriate though to record in the minutes the offer of the Borough Council to fund the new X-ray equipment, either in the form of a loan or outright purchase. It was a substantial loan. It was seriously meant. It was. We went into the finances of the council, and we thought that we had enough in the reserves which we could justify allocating to this purpose. But I don't see any mention of that. I mean, whether in fact the offer was instrumental in the eventual outcome, I don't know. But the offer was made, and I think it's worthy of note. And the last
David,
point,
I'm not sure how we can put something in a minute which isn't mentioned in the paper.
well, I'm asking why it wasn't mentioned in the paper, Jeff.
Enough, but it wasn't.
Exactly. Yes.
I'm talking about the NHS here, not Hinckley and Bosworth Borough Council.
The NHS, I would have thought, is owned by ourselves. It's not a separate body which administers its own affairs for its own purposes. You know, the people I represent are also patients, and I regard the NHS as I think it's the highest priority of all our public services, followed by education. Neither of which we have much direct input into, but nevertheless they're the two services which I think that we should take the most care of, and that's why the offer was made to fund the reinstatement of the equipment. But anyway, that's by the way. When I read this report, it occurred to me that we really ought to re-examine the transport arrangements to the community hospital. The community hospital, for those of you who don't know, is on the outskirts of town and is in a remote location. And I sent a note yesterday to the CCG drawing attention to the fact that if the community hospital is now going to have a greater use, then we should at the same time encourage the transport authorities and possibly the CCG to ensure that people can actually get there safely. And I drew attention to an incident which had been drawn to my attention earlier on this week about 3 elderly patients who had been waiting for the bus outside the hospital, having to come back in from the cold because they'd waited for the bus and it hadn't arrived, and they were going to be left by an open field, which is hardly conducive to their recovery. So I'm just wondering whether on that point I could ask the committee to at least note that there is a need for improved public transport to that location, and perhaps whether this committee could ask the transport authorities to see whether anything can be done to meet the needs of the people.
Yeah, thank you very much, David. I mean, on the basis that where this X-ray is being moved to is the same location, except the other side of the corridor, effectively, presumably the same things will apply whether the transport's there or not. I mean, it is basically the same place that it always has been. It's not.
No problem with the X-ray machine being moved into next door. It's the
transport to get to it.
It's on item the second bullet point on page 159, creating the combined day case surgery and endoscopy unit.
That's Sunnyside.
Sunnyside, yes.
Right.
It's the reference to Sunnyside, which in fact weaves in and out of this report, which I think really requires attention.
I'm probably pretty sure you don't want me to respond to all of those comments. Would you like me to respond? Okay. So, on the long and winding engagement piece, I think it's been really important that we have engaged with the public in Hinckley to determine what the best course of action is before setting out our strategic plan to make change happen. We do then, unfortunately, after having approval of our strategic outline case and having the funding allotted to us, we do have to go through a really rigorous process to spend taxpayers' money in an effective way. We don't want, you know, from an NHS nationally perspective, there is a tough process that we have to get through. We don't want to end up at the end of it with a hospital that's too big or too small when we're making significant capital investments. This one is only £7 million, but we need to follow the same kind of rigour and process that is required for, you know, building a multi-million-pound hospital or a fairly small capital thing such as this. In terms of the loan, I didn't include that in the paper because I didn't think it was relevant to the decision that I'm seeking today. I have written back to the council and shown my gratitude for the offer of a loan, which unfortunately we couldn't accept due to the way that our financial regime works in the NHS. That wasn't going to be possible for us. And actually you made the point that it may have been helpful, and I think actually it may have been helpful in helping us to secure the funding from UHL, because I certainly used it personally in discussion to say, you know, there's quite a bit of energy around this from the local council. I'm coming under increasing pressure. They're even offering to lend me the money, which of course I can't accept, and I think that may have helped to secure the funding ultimately. In terms of the transport piece, we will, you know, consider the impact in terms of patients and transport and bus routes, but you know, obviously we're not responsible for that, and we'll do that in the forthcoming pre-consultation business case. So we'll be setting out what we think it means in terms of travel arrangements when we do move the new services up to the Sunnyside site. But at this stage, as the chair says, we are just looking at moving X-ray from one building to another building in the same location, which is in the centre of Hinckley.
Thank you, Spencer.
Well, yes, I know the NHS has to take its time, but we're talking about 20 years. So I think we have we have cause to comment that, and in fact I think it might even be sooner than that. But my records start around about 2005. But I rather suspect I was involved previous to that. It would be very useful if we could have those comments recorded, please, because it's.
Yeah,
I think especially I'm concerned about the bus. If that aspect could be written into the consultation, I think it would help. It would help to collect people's views and hopefully ease the way into making progress.
I mean, we're not actually being asked to comment on the consultation, you appreciate. All we're being asked to comment on is actually moving the X-ray. However, you've said it, and I'm sure it'll be minuted.
Are there, aren't they, on page 159? Spells out the programme, and I would have thought it's incumbent upon us. Yes, I would have thought it's incumbent upon us as county councillors to ensure that patients can actually reach the hospitals, even though the NHS is not our responsibility. I think we have a duty of care to the people we represent. Sorry, I know that goes against the rules.
Well, all I'm saying is today's decision is actually to help them get the X-ray moved, not to sort out the whole of the business case.
As far as I'm concerned, Chairman, the NHS belongs to us and is not a separate body to which we have to, you know, just agree with everything they say. Sorry, that's just my point of view. Yeah.
And you need to talk to your neighbour there about how long it takes to get money for community hospitals. She and I have been working on it for over 18 years. Anyway, next person.
Thank you, Chair. It's a bit of a kind of a... I'm not going to go into too much detail, but I would just kind of remind Spence about what happened with the intensive care beds when the decision was made not to consult, and just to remind the committee that actually it's not your decision to make if they consult or not. You don't. That's not something they can put on you. But I think they kind of. I suppose there's a question about if you do move the X-ray machine, would that actually impact on the actual consultation that you're then likely to hold? Because does it shift the kind of how the response might be? Because if you've already done a part of what you're consulting on, does that then kind of make it more a fait accompli?
We don't think so. I'm not here to ask this committee to support us not consulting with the public. I'm here to consult with this committee to get their support. So we have decided to consult with this committee, but not to consult with the public. I don't think that it predetermines the outcome. It is the removal of essentially one room's worth of kit from a small community hospital into an adjacent building. I don't think it then leads to, well, actually that obviously means that the rest of that, it then becomes inviable, because I think our view has always been that the old hospital is not suitable to maintain and sustain provision of modern healthcare. That's what the whole basis of the proposals that we will come forward with will be about. Moving one room out of a number of rooms that are operating within that hospital doesn't predetermine the outcome. It's a small move from one. You know, it's not like we're taking 80% of it and moving that, and then we turn around and say, well, there's hardly anything left. The majority of services that operate from that hospital will still be there. So it's a minor alteration from that hospital's perspective, and from actually the hospital that it's going into the health centre. There'll be a minor impact in there as well. But it is in line with the direction of travel that we are going to set out for the public consultation that will be forthcoming, but it doesn't predetermine the outcome.
Amanda.
Just, I mean, obviously this meeting, this committee sat just a day or so after the announcement to close, so to actually get a paper to the next committee, I know timing's difficult in the NHS, that feels pretty quick to me. So, you know, I think that it's a positive step forward for services at Hinckley that the X-ray facilities, you know, the machine's busted, we've got a plan for it. I suppose that, you know, from my point of view is how long are patients in Hinckley going to be without a service? How long is it going to take to establish it? You know, those individuals that are getting X-rays at the moment from the local area, where are they being diverted? Are they being given a choice? Is that convenient? Is it, you know, suitable for them? And how is that being managed? But I suppose the other question, and again, I don't know whether I'm stretching the boundaries of the paper, is about NHS resilience, because clearly this machine was pretty much on its last legs when it was decommissioned, and it'd gone beyond its usable life already. So it wasn't a huge surprise that we were going to have to, you know, that decision was going to have to be made. It had gone beyond its useful life. What kind of risk do we have within, you know, your patch of other facilities going the same way? Are we comfortable that we have the resilience? Because obviously reacting to something that's broken is a more difficult solution than actually replacing it when we know it's going to be up for replacement, and that can be done in a more smooth process. So, you know, we're being asked today, can we move the X-ray facilities from one building to the next building outside of a consultation process? But actually, if it had been planned for, then it would be a much easier conversation to be had. So it's just a sort of a, you know, I'm happy, but it's a bit, you know, it's frustrating that it's come to this point, so that would be helpful.
Okay, so pick up the patient bit first in terms of what are we doing. We're diverting patients either to Colville or the Glenfield. So arrangements were put in place for that straight away. We did do a report actually to the Hinckley and Bosworth Scrutiny Committee that focused more on that, because that was the issue that we were dealing with at the time. You know, how do we make sure that we are resilient? So that was, you know, our response, and how we made sure that patients still get access to the services that they require. I think, you know, if I'm honest, recently we have been hearing stories of patients who are saying, actually, I don't want to travel, so I'm not going to have an X-ray done. I'll just see if it kind of starts to feel better in a couple of, we're starting to hear those sorts of things coming through. So that's a concern, and we do want to put this back in place as soon as we possibly can. It will take time though, because we will need to make sure that the room that it goes into is suitable to house an X-ray machine, lead lining and that sort of thing. So that will take several months, and then somebody will build the machine for us. So given that the capital funding is only available to the end of March, I think I would feel safe putting the end of March as a date by which we would get this done. But I would hope that it would be done sooner than that, to be honest. But I don't want to make any promises that we won't stick to, and I think we would be able to get it done by the end of March, as long as it's supported here, and then we get the final approval within the CCG, which I'll be looking to do next week, and then we'll be mobilising people to make a start. In terms of the resilience of the NHS at large, this is I don't know how much we've explained this before, this is a really strange example, even in NHS terms, where, admittedly sometimes some of the financial rules are hard for others to understand. We are a really unique case in Leicestershire. We're the only place that I know of in the country where assets used to belong to the commissioners, and we should have passed them over to the providers. And in our community hospitals, because we have so many community hospitals, they remained the possession of the commissioners. And commissioners don't have an easy way of accessing capital funding, which providers do. So, usually providers regularly are replacing their equipment. They have rolling replacement programs, and they use their capital funding to do so. The CCGs don't have any capital funds, and this capital equipment belongs to the CCG. So we haven't been able to do that. So that's one of the key reasons that we were trying to build the longer term plan for Hinckley in particular, because we knew that there were issues here. We are still working on a solution to that, which is a risk across Leicestershire, frankly, in all of our community hospitals, and we're trying to transfer the assets that we own as a CCG over to UHL as the provider of most of the services. But that is proving more difficult than you would ever imagine. And that therefore means that our community hospital equipment is less resilient in terms of our ability to replace it and keep it up to date. It's not there at this point in time, and we're pursuing that issue with NHS England. But it's difficult, and I think this has really illustrated the point to them that we've been trying to make for the last 2.5 years. We've been chasing this issue. This has illustrated the point that actually it does lead to real world problems, the fact that we haven't been able to resolve it. So I know that's perhaps not giving the assurance that you would like to hear, but we need to get the equipment transferred to a provider so that they can form capital funds and purchase replacement kit.
I wasn't aware of that, must admit. That's something I've learned tonight.
We are different.
Mine's a personal and a positive comment, because I was actually one of the residents that actually got diverted to have an X-ray, either at Colville or Glenfield, but because I spend quite a lot of my time here, Glenfield was obviously the choice. And to be quite honest, whether it's a choice of turning right instead of left in the same building that I'm used to, I will take that every time, rather than trying to do a journey over to Glenfield or Colville. I mean, it's very important, because where I am and my GP surgery, it is very difficult to get to Glenfield or Colville via public transport. So this going back, for me, my family, carers, etc., from a personal experience, is a real positive. So I'll end on that positive note.
Yeah, thank you very much, Becky. Tom.
I think sort of the thrust of what we're trying to do today is, as a committee, recommend that we we put an X-ray machine in a building to the right of where it is, to make facilities available in Hinckley to the residents, instead of having to travel to Glenfield and Colville without consultation. And it's pretty clear that the people in Hinckley want the machine, and Chair, I would propose that's exactly what we do.
Very much, Tom. I think that's well.
You've already touched on this, Chair. the high NHS finances are tortuous. The experience in Market Harbour was that they'd get partway down the process, the government had changed something, and they'd restart the process again, and over £1 million was spent on consultation over the years. So, yes, it's important to be careful how you spend public money, but it can be so slow that the national framework changes around you. I mean, pleased to say in this case, we've got the money sort of there, desperate to be spent, but yeah, it's not altogether a good thing to have a slow and detailed process when the national situation changes faster than your process does. Thank you, Chair.
David again.
I would move that we welcome the report and look forward to the installation of the new equipment.
Thank you very much. So, we don't actually formally a motion, but I mean, people generally are happy about this. I mean, I think it seems an excellent plan, and get on with it and get it in. Thank you, Spencer. Thank you very much.
Thank you, Chair. So I've set aside about 2 hours to take you through this report, if that's all right. So as you said, so the purpose of this report is to present my annual report for 2019. The usual reminder from me for scrutiny members that I have a statutory duty to produce an independent report as Director of Public Health on the health of the population. In terms of why I chose this one this year, you may recall the last two I've taken a largely infographic and data approach to the reports. A couple of years ago, we looked at an overview of the population more generally, and then last year I focused on multimorbidity and frailty. And there were recommendations in there. They were fairly broad, because really the idea behind using the infographics was to stimulate a debate around the health of the population, around multimorbidity and the older population more generally. This year I've been a little bit more directive in terms of choosing a particular topic, which is physical activity, and also been a bit more directive about what I want to get out of it. Now, the reasons for choosing physical activity was that it was driven by a concern around some figures that started coming out last year through Sport England and their Active Lives survey, which suggested that physical activity levels in Leicestershire were A, below the national average, statistically significantly below the national average, and B, they dropped over the previous 1, 2, 3 years. And on the back of that, I took a paper to Cabinet. We can't remember if we had a discussion at Scrutiny on that particular issue about the need to consider what a whole systems approach to physical activity would look like. So this year, I've looked at, in detail at physical activity and what that whole systems approach would mean for Leicestershire. Just to cover the stats bits first, there's still plenty of data in there. I think I'd draw your attention to 2 or 3 areas, one of which on page 174 of your meeting pack, the report gives an overview of Leicestershire's physical activity profile. So it's the sort of that grid. I won't go through it in detail other than to say red is where Leicestershire is significantly worse than the national average. Amber is somewhere along a similar to the national average, and green is better. And my summary would be looking at that. There's not enough green. And really we should be, and that's against the national average, and always say from a Leicestershire point of view, given our levels of deprivation, given the place that Leicestershire is, we should be challenging ourselves to at least be as good, if not somewhat better than the national average. I'd also take you on to page 182. So I've put in, where I've got it, district level stats for each of these areas. And again, if you look at the figures for each district, around a couple of measures there, the percentage of adults aged 16 plus that cycle or walk to work, so it's for travel as opposed to for leisure, for more than 3 days a week. Again, I won't go into the detail other than to say there's too much red on that table. But it's not all doom and gloom. If you look on page 185, which looks at early years physical activity, although it's a mixed bag, and those greyed out areas on the 2 diagrams give you a sense of the breadth of the confidence intervals around the statistics, you would see that when it comes to children's physical activity, it's not such a bad a picture as maybe it is around adults travelling to work in the previous slide. So there's plenty of data in there, which I'm sure you've had a chance to read. In terms of what we do about it, I am advocating a kind of seven key areas that we need to tackle, which are set out in page 177 of the meeting pack, page 9 of the report, I think. Is that right? Hold on. Let me just check before I commit myself to that. It's page 177 of the meeting pack, page 9 of the annual report. And that recognises that there is no one magic bullet or one solution to tackle, which are fairly ingrained reasons why we don't do enough physical activity and why that's changed and gone down over the last 20, 30 years. But they are that we need to take action on making active environment. So how do we build in physical activity into the infrastructure that we've got in the environment? Active travel, more obviously, how do we encourage people to ditch the car and take the bus and cycle and walk to work, etc., etc. Active years and schools, so how do we encourage children to be physically active from an early age? That's wrapped around a whole family approach, so we need to focus on active people and active families. The best way to get children active is to get the adults active and vice versa. Also recognises active workplace and active workforces as a key agenda, given the amount of time we spend at work. And active communities. So generally, outside of all these individual bits, we've a need to motivate the community to take responsibility themselves, to think about what can they do to be more physically active. And then the other one, the only one that's not got active in front of it, is physical activity as medicine. So recognising that physical activity is probably about the best biomedicine there is, given its impact on physical health and mental health for a variety of conditions and illnesses. Throughout the report, I've given a sense of what are we doing at the moment and where do we need to get to. It's not a full list of everything that we're doing in Leicestershire, because that would be a lengthy report, but I hope it gives a flavour for some of the work that that we're doing. Probably should mention in particular the work that Liz Orton in my team, Consultant in Public Health, and Dave Stock. Now, Dave works for Leicestershire and Rutland Sport, but his post is part funded by local money through LRS and partly through Sport England. He's essentially working on behalf of Sport England to push this very agenda. So we've been working closely with Dave to get together a group of leaders, district council, chief execs, other planners within districts, sport and physical activity people and colleagues within environment, transport and public health within the county council, to create a cohort which isn't just about tackling each of these individual points, but it's about providing that system leadership to this whole agenda that's around a whole systems approach to physical activity. So there's a lot in there. There's a lot we're already doing, but essentially I think the priority for me this year is to work with Dave and with others to make certain we really land this kind of active design whole systems approach to physical activity. But I'll pause there, Chair.
Thanks very much, Mike. Very helpful.
Thanks a lot, Mike. Can I just say congratulations on the report. I have to say it was a great read, beautifully presented, very clear, succinct points, easy to understand, coherent, all the great things that to actually be sitting reading something, a joy. So thank you very much. As a result, you got across the points you were trying to make very, very well. So I'm not really going to say much more about the report because there's not a lot to say. I completely get all the points in there. Interesting enough, I've been having in Loughborough having discussions with the Youth Sport Trust. A lot of the occupants of Sports Park and the university and also Loughborough College about this particular issue in relation to young people and how we can actually focus a lot more on trying to actually see some of the benefits of physical activity in some of the harder reach areas. And as such, I will come and see you very soon because we have a project that we're just about to kick off, which I think having the County Council as part of that would be superb. Thank you.
Yeah, more than happy to be involved, of course, with Leicestershire and Rutland Sport being based at Sports Park itself. Again, I would imagine Dave and John Byrne, as the Director of LRS, would be key to that conversation as well, so we can draw them in as we go along.
Ted?
I was curious as to the how some of the data was gathered, but fortunately there was a small key, and the Sport England they gathered their data by, and I looked on the internet, it was through random sampling letters, wasn't it, sent to people. So this what work is taking place that really tandems this in terms of diets and specifically cutting sugar down? Because of course it was Sir Simon Stevens who said that famously that sugar is the new smoking.
Yep, could do a separate. I could do a whole report next year on diet and physical activity. There is much. Where do we start? From a public health point of view, we provide a range of things. There are services for those who are obese and overweight. So on the 1st of October, we brought the weight management service that was previously delivered by Leicestershire Nutrition and Dietetic Service in-house. So it's now part of the Public Health Department. We're in the process of supporting current patients whilst we just open up that offer to the rest of the population. So we do have a structured programme for those who are obese and overweight to encourage them to lose weight, is one. We then also still provide, even given the budget cuts we've had within the public health grant, the kind of universal offer and support. So that includes funding for Food for Life, who work with us to do things like cook and eat sessions, food growing sessions with schools, for instance. So that's probably the biggest programme in the country that Food for Life deliver. That's alongside the Healthy Schools programme that, again, we still deliver within our schools or support schools to deliver, which would focus on diet for young people. Through First Contact Plus, our information, advice and guidance service, we would direct people to source of support around healthy diet as well. And I've probably listed a load of other things around diet that we do. Overall, we have a food plan for Leicestershire, which I think we took to Cabinet. Again, I can't remember if we ever took it to scrutiny or not, which would celebrate, again, a whole systems approach to food in the same way that I'm advocating a whole systems approach to physical activity, recognising that food is not just about healthy eating, but it's the impact on tourism, on industry, because of the food industry that we've got within Leicestershire. And it's almost a parallel of the physical activity bit, working with district councils, working with industry, working with employers around food. So we've got a fairly good record of what we do around food and diet. We are the first. There is an organisation, the Sustainable Food Cities organisation, which have a number of tiered awards, bronze, silver and gold, and I've certainly done a report before. We are the first county that is a member of the Sustainable Food Cities initiative, because most of it's geared around places like Brighton and Bristol, which have been very successful, and their approaches to this kind of whole systems approach to food. We're there. They are very interested in working with us on that, because alongside our district colleagues, they see that they need to get into working into 2 tiers into county areas as part of their work. So we've got a fairly good record around food, both in terms of service provision and the broader system leadership and policy work as well.
Thank you very much, Mike. Very good. David.
Well, as Jonathan says, it's an excellent report, which is quite clear, and I think really we should make it available to district colleagues as well for their, and I think it fits in well with the next report about air pollution, the need for all of us to exercise more and use cars less. I'm just wondering, Chairman, does delivering election leaflets on an endless basis count as positive physical exercise for the... I can see some nods around the room.
Well, you probably noticed that I am now considerably slimmer than I was about 4 years ago. And I put it all down to delivering election leaflets.
Yep, just picking up a couple of points. So district colleagues have been telling them for a while that I'll be focusing on physical activity, so they've been chomping at the bit going, when can I come to the district and borough council health and wellbeing partnerships to take them through the report. Scrutiny, I think, is the first time it's gotten a public airing, so now it's out in the public arena, I can do that. Ditto working with LRS, because I know John Byrne would want to share that. And of course, it's not just the steps going to the letterbox that would help with the election leaflets. Running away from barking dogs and irate constituents would probably count even more.
I think my biggest issue is the height of the letterbox. It's when you go along a whole row and there's one height, bottom height. So it's really good, very good exercise for
that. I've got to agree, it's a very attractive report, so it's easy to negotiate your way around. No but. Well, just a little one. On page 5, or page big 4, on the why physical activity is a problem. It's just on your diagram, where you've got 21% of boys and 16% of girls aged 5 to 15 achieve recommended levels of physical activity. And then across the other side it says 23% of girls aged 5 to 7 meet the recommended levels of daily physical exercise activity. But by the ages of 13 to 15, only 8%. So I'm querying that, because you've got 5 to 15 on one, and then the 13 to 15, so I'm not quite sure where it goes amiss.
Yeah, I see what you mean. So somewhere, 16% of girls
I'll
aged...
just leave that one with you.
No,
Okay. Because I can't work it out.
Here's the draw. So there's a reverse, isn't it? So 16% of girls aged 5 to 15 are achieving recommended levels. That was just at 84% aren't. By the time you get to 13 to 15, 92% aren't doing enough, the 100 minus the 8. So what's the issue? I suppose the important thing with that is not so much when it drops off, but there is a sense that when you are younger, so up to the age of 5 to 10, things aren't so bad. Particularly for young women, sports and physical activity levels just drop like a stone for a number of reasons to do with puberty and periods and body image and exercising in front of people and the rest of it. So.
No, it says on both of them, doesn't it, that it's 16% of girls between 5 and 15 achieve recommended levels.
Yeah.
But on the other one, it said if you're between 13 and 15, you only get 8%.
Yeah, so it tails off.
Yeah,
Yeah. Yeah. So it's confusing, but because it's different age groups. But there is the tail that would say, that 5 to 15. It's like 5 to 15, this amount are doing it. By the time we get to 13 to 15 as a subset, there's even less that do the recommended levels. And I suppose that's the important bit, is those early teenage years where we know, particularly in girls, that sport and physical activity levels do drop off.
Okay.
So those Sport England campaigns, This Girl Can campaign, was a deliberate attempt to try and get physical activity levels up in that age group.
Okay, thank you. But you see, it was only a little bit.
There wasn't a but there at all.
No, not really.
Probably no buts.
Amanda.
Thanks. As other colleagues have said on the committee, I mean, this is honestly my favourite report of the year. So I love data anyway. It's my sort of thing. I just wanted to sort of hone in on the active travel page. So that's 182 for the pack, or 14 for the paper. And it's certainly something that I've been babbling on about in full council for some time, particularly about journeys to school and the safety of those journeys to school, and have highlighted one or two where safe routes to school aren't really that safe and quite close to cars that are going 60 miles an hour. And I think that for us to really get to the bones of physical activity and why people do or don't do physical activity, I mean, I run regularly, and I think one of the things I would say is people put barriers in the way not to do something more than what they do to do something. So the easier you make something, the more likely they're going to do it. And my plea really is that we have safe walk routes. We have routes all around Leicestershire. They've all got numbers. They're not safe to walk and cycle. We need to make them safer. Because I'm a parent of a 9-year-old and a 12-year-old, and there's certainly things that I wouldn't allow them to do now that maybe I would have done myself as a kid. And good habits are forming for a lifetime. And I think Mike's completely right. 13 to 15-year-old girls in particular, and I'll go back to my school days, it does drop off really, really quickly. I was always included in sport, and it's continued throughout my life. But I think that is a really important step that we try and encourage, particularly our teenagers, to continuing to be physically active, because it will continue through their lifetime.
Yeah, I'd agree. Just going back to the previous point, I should actually be picked up on using gender stereotyping of blue for boys and pink for girls, but I just realised that was more the glaring error. In terms of active travel in school, I mean, I think it's almost a worked example of everything we need to do. So there are some things that schools do, that you know, the kind of initiatives to try and deal with the problem there and then. So the kind of walking crocodiles, when you get the kids, you know, with the high vis on and walk them to school. As I said in the briefing, you'll know I attended the Leicestershire Rutland Sport Conference last week, and there was a guy, Stefan, his surname escapes me, who's a lecturer either at Loughborough or Leicester Uni in kind of active travel, was talking about a few things, one of which is the cycle lanes that we predominantly have in this country, which are just kind of the white paint, the hatched lines, the cross lines on the roads, pretty much neither use nor ornament compared to a proper designated separate cycleway. And then there's junction design, and as he said, if you're a pedestrian, we'd spend a lot of time doing junctions which kind of nicely curve out so you can sort of turn your car nicely, but of course that just increases the distance that a pedestrian needs to walk, and then you start thinking about, do you walk there to cross the road? And you don't. Whereas actually, if you go back to the basics of almost having a straightforward T-junction, all right, you might clip your alloys on the curb every now and then going over the corner, but that would make such a difference from the point of view of how the pedestrians perceive the ease with which they can just do simple things like cross the road. So, even for something simple like a walk to school, it encompasses everything that's in the 7 points.
Michael.
Thank you, Chair. Yeah, it's difficult to really disagree with anything in the report. I think there's a couple of things that I was particularly kind of interested about. They're kind of talking about trying to get families active, and I think that it's certainly kind of rings true for me, kind of thinking about it, kind of turning it into a family activity and something that it's taking away that kind of chore element of physical activity, which I think is a barrier for a lot of people. I came to physical health slightly later because I was diagnosed with diabetes, which actually was a big of a shake to me to really kind of move it forward, and it's now managed. I think also the kind of the biggest challenge that you've got, but also fundamentally might lead to the biggest impact, was about the active workplace, and I think trying to kind of, because that kind of ties into the kind of physical exercise as medicine as well. And I'm really keen to see kind of how that kind of develops and grows.
Yep. So of the two, I guess active families is more established. So there's obviously the sport and leisure offer that district councils provide, but over the years since we transferred, we have put money from the public health grant into supporting districts to do specific programmes of work around making the inactive active. So largely around condition-specific stuff. So walking groups for people with a particular condition. Workplace health, I guess, has gone up the agenda, or has come back up the agenda in the last couple of years. It obviously was there about 10 years ago, but money went west, and we've put the effort through some funding from public health and some joint funding from across the district and borough councils to support LRS in taking forward the workplace health needs assessment, and then a programme of work to help employers think about the health of their employees more generally. So that's one where we're probably starting from a lower baseline where we've got more scope to have a go at.
Yeah, you raised a point there that I should have mentioned earlier. We have a walking group, in fact, several walking groups in my area, but one of them is really struggling at the moment because they want to specialise in taking out groups of patients with either dementia or autism, and they're being hit by the fact that they have to take out insurance in order to protect those patients from any possible harm they may have, and it's caused a real, just can't do it. They can't get the money.
Thank you, Chair. It's always nice to pay compliments, but once again, a good report. I think, like most members around the table, I do enjoy this report. It's very factual. I think this one's interesting because a lot of it is about choice. It's for us to actually make that difference. So I think the subject this year is very relevant. We had on Monday, we had the Chief Executive from Public Health England attend Leicestershire County Council, and we had a round table discussion with the NHS and also Public Health England sort of regional partners. And it was interesting the fact he paid compliment to not only the fact we have a long-standing Director of Public Health here, which makes us very effective and very efficient. We have a good reputation within the country, which is good, and I think, again, that's down to Mike and his team. Good practice. He also talked about scrutiny, the fact we deliver good scrutiny here. We have a good health and wellbeing and effective health and wellbeing board. And he certainly saw us as the way we deliver our statutory services in Leicestershire is very well known. We have a very good reputation. He wanted to find the reasons for that. But he certainly talked about the fact that around this table and what we do is in Leicestershire, we deliver those services as well. So just really the other point of Mike's report was the feedback on page 196 on the 2018 requests. I think that's very informative as well. So yeah, thanks to Mike and his team, and yeah, good report.
Thanks very much, Lee. That's really helpful. It's good news as well, isn't it? Sarah.
Thank you, Chair. Again, I've written out what other people have said. It's a really good report. Interesting. There's always good stuff in here. I await with excitement the fact that highways are going to have a Damascene conversion in favour of pedestrians. Particularly, I mean, even if it's only recommendations on the end of planning advice, I think that would be a good thing, because currently in my view, they're obsessed by cars and it's hard to get pedestrians noticed. I remember Ernie White saying that in Blaby they did a thing where they had a league of who did most steps, and the person who consistently won wasn't a lady who was in the shot. She was a lady, she wasn't in the gym most, she had a dog. So if you want to get fit, get a dog. And my only comment on this, and Mike knows what I'm going to say here, is whoever did the graphics was obsessed by running, because there's lots of images of people running, and we're actually saying here walking is, for most people, walking is the most easy, effective, and possible thing you can do. And it's obsessed by, you look at all the graphics, they're all people running, and then when it says 176 physical activity for adults and older adults, apparently women dance and men do everything else on that graphic. So that's me just being facetious, but yeah, thank you, Chair. It's just whoever. It's not. I'm sure Public Health didn't do the graphics on this. I'm sure it's another bit of the County Council, and they may need some polite feedback. Thank you, Chair.
Yep, so there's 3 points now I'll respond to. If you see me dance, it's probably just as well that graphic stays as it is. You are right, and I think really it's just the kind of the way that stock images work out. But I will, it would be good to sort of sit down with comms and think, actually, if we got other images that we can use that isn't just about running. Picking up on the planning bit and the highway bit more seriously, I think we've mentioned it a little bit in here, and if not, obviously developments like Lutterworth, where the County Council's got the kind of lead development role, are giving us an opportunity in public health terms to work closely with corporate resources and others. Simon Lawrence is the major programmes lead around the design of that. So thinking about 20-mile-an-hour zones in there, getting into discussions about community severance when the Spine Road runs all the way through the middle of it. That's been a fantastic. We've done stuff before, some input into Lubbersthorpe, etc., but Lutterworth is a really key one, really, in terms of thinking through as a county council how can we help build in physical activity early on.
Very good point. And obviously a well-received report, so thank you very much for that, Mike. I think everyone's had their comments about it and it looked well. Did you want to say anything else? You're about to go, yes, I could tell this. Yes, I could sense the hesitation of the Charnwood group. Yes, I know. So we move on to the last paper. Indeed. Yes, and you check out your air quality, I'll tell you. Yeah. So, Mike, please continue with the air quality. Now you're being given the gadget.
Yep. So I'll keep this fairly brief. Just in terms of the history of this, there's probably a couple of things to cover. One of which I think when we did have one of the Scrutiny agenda planning meetings, there was an interest expressed in air quality, so I said I would do something about air quality. And then separately, Environment and Transport Scrutiny Committee considered a paper on air quality or clean air, I forget the title of it, last month, of which Public Health had some input into that, because clearly we're working closely with our colleagues in Environment and Transport on broader issues around active travel and air quality, etc. Now, I didn't want to bring that paper here because it wouldn't be right for a paper previously considered by Environment and Transport to be considered by Health. What came out of that discussion at Scrutiny was a desire from members, notably Mr. Payne, that we develop on the back of that conversation a plan on a page, almost a kind of plan about how the council would wish to engage with partners such as district and borough councils to do almost a similar piece of work. How do we all work together to address air quality? We're currently working on that, and provisionally I'd like to take that to Cabinet in 2020, probably the early part of 2020. So what I've done is a presentation which is almost a primer in my mind around air quality and health, with a view, I would imagine that when we develop the plan for clean air and air quality, that we need to find a way that health scrutiny is able to participate in that conversation as much as environment and transport. So for members who are probably well aware of this, particularly twin hatters who've got sort of planning responsibilities, apologies if I'm going to take you through a kind of suck eggs overview of air quality and health, but I'll just plough through. So the slides generally are about a couple of years old, and I've updated a few of them. But I suppose as you would expect, obviously you'll know over the last 2 years the amount of interest and publicity there's been around the effects of air pollution. 10 years ago, I don't suppose we were talking very much about it in public health terms. Even 5 years ago, we weren't. All of a sudden, it's right up there in the kind of top list of priorities that we need to consider, either through physical activity or the health effects. This was published back in March 2017, which was a briefing for Directors of Public Health jointly across LGA, PHE and DEFRA, in terms of just making us aware of what we should be doing as Directors of Public Health. And the slides largely draw on that. So, what are the main air pollutants that we're talking about? Obviously, people talk a lot about transport and air quality, but it's not just about transport. So there is particulate matter, so what's called PM10 and PM2.5, and again 2 years ago this was probably new, but you're probably all well aware of this through the news. Those kind of minute but solid particles of matter that are emitted by diesel exhaust, for instance, would be a good one. I suppose a couple of things, one of which is air pollution is not a respecter of international boundaries. So 55% of PM10 and 2.5 comes from the UK, but 45% doesn't. It's kind of blown in on the wind from abroad. 38% of UK emissions, depending where you are, come from household solid fuel. And again, since we first did this presentation, you'll have seen some of the stuff around wood-fired stoves and the health implications of those. Does depend where you are. Obviously, if you're in a city that's burning this, so middle of Kensington or somewhere posh in London, it's probably more of an issue than some places. NOx, the oxides of nitrogen, be it nitrogen dioxide or nitric oxides, the largest source nationally is transport, notably from diesel vehicles, both cars and light vans, as opposed to heavy lorries. Sulfur dioxide, now decreasing amounts of sulfur dioxide because we're just not burning as much coal, but 46% of sulfur dioxide emissions come from coal burning in power generation. But then there's things like ammonia. So 80% of ammonia really is from anaerobic digestion and fertilizers. So if you think about the role of agriculture in pollution, that's one where the anaerobic digesters that farms tend to have, and spreading fertilizer-related ammonia into the atmosphere. Then the other one, again, largely driven by transport, is ozone. So normally think of ozone as being a nice thing, what you get by the seaside, but it is a pollutant and indeed an irritant. And volatile organic compounds, and again, the most obvious one that I'll have come across, I'm sure you have as well, is if you ever buy a tin of paint, you always get that little rating as to whether it's very high in volatile organic compounds or down to low. So a number of pollutants. I guess the main thing is don't just think about it as being car pollution and NOx, which is what people concentrate on, or PM10. There are the others down the bottom of the list. What are the effects on health? So it is the largest environmental risk to health as opposed to a lifestyle risk. Contributes to a wide variety of diseases, cardiovascular disease, lung cancer and respiratory diseases being more obvious. Again, we tend to think of lung diseases as being the more obvious one, but it gets through. Going back to PM particulate matter sizes, the smaller they get, the quicker they are to get through your system. So by the time you get into particulate matter 1, so 1 picobyte or whatever it's called, by the time you get to that level, it's kind of able to move sort of straight through your lungs and into your bloodstream direct, as opposed to clogging up your lungs and then causing cardiovascular disease. So quite a wide range of health effects. Particulate matter 2.5 tends to be, because of its size, the stuff around PM1 is a bit more kind of, not experimental, but pushing the boundaries of the science. Has the highest link to health outcomes because smaller sizes tend to generate more health effects. What does that mean? Well, obviously, increased chance of being admitted to hospital, turning up at A&E, or indeed just dealing with longer-term respiratory and cardiovascular systems, which just kind of get in the way of everyday life. And as you'd expect, disproportionate effects on vulnerable people, those with preconditions, those that live near a point sources of pollution tend to be more vulnerable anyway because it's related to affluence, etc., etc. So in terms of the figures, Now, again, I think I first used this for a North West Leicestershire presentation, which is why NWLDC is in yellow. Yeah, up the somewhere up there. It doesn't quite show up. It's that one, as opposed to the other districts. The key points that lists all the districts in the East Midlands. Left-hand side is the England figures and the East Midlands figures. And what this shows is the methodology behind this is if you thought about how much does air pollution cause this percent of cardiovascular disease and this percent of cancers and this percent of respiratory diseases. If you add up that sort of fraction of responsibility, if you want to call it, across all diseases, it gives you what's called a mortality attributable to particulates of air pollution. Now, it is a kind of worked model because I think there's one example of the child in London whose cause of death certificate said air pollution, and she was an asthmatic. So it's not based on death certificates, it is a kind of modelled one, but the science behind it is pretty good. And as you can see there, so I think it's around about sort of 5.3% of all deaths in England are attributable to air pollution. It's higher in the East Midlands, so again, why is that? Middle of the country, we've probably got a bit of transport, bit of agriculture, a bit of everything that's driving it. And you can see with the highlighted districts, it varies from, I think Harbour is the lowest there, down somewhere just about 5, up to Northwest Leicestershire, I'm sure is the highest, which is about 5.9 from memory, he says, looking over my shoulder. Yeah. So, it is an issue. So it's an issue in itself. Even if we were lower than the national average, a bit like physical activity will be going, it's something we need to take account of. But for a number of reasons in the East Midlands and across Leicestershire, it's higher than the national average, which is an interesting finding in itself. Nationally, what does that mean in terms of mortality? So there's a report by the Royal College of Physicians, Every Breath We Take, which estimated that they reckon there was about 29,000 deaths a year in the UK caused by inhaling particulates, which on recent evidence was expected to rise to about 40,000. Now, like all these things, there is a level of statistical variation in what that might be. So it could anywhere be between, the 29,000 could be anywhere between 5,000 and 60,000. Wide variation depends whether you go with the optimistic model of 5,000 or whether you start looking at 60 and going, actually, this is somewhat worse than we thought it was. How does that relate to other areas? If you take that model of expected 40,000 deaths a year due to particulate matter and air quality, it's not equivalent. It compares to smoking, which still causes about 80,000 deaths within the UK. Alcohol, shy of 10,000, obesity 30,000. So if we think about obesity and smoking as being the two big lifestyle killers, air quality is on a par with that. And I guess it's a line that Rob Howard in my team's used before now. Actually, if you took away air quality and said water quality and said 40,000 people were being poisoned by bad water in the UK and dying as a result of it, we wouldn't be having a briefing presentation from me at Scrutiny. We'd be out there going, what's happening with our water supply? So it's interesting if you think, well, why do we treat air different from water? It was an interesting one. Where does it come from? And again, the main point for me is just to say, not to just think about it as being road transport. So industrial processes generate air pollution, particularly around PM and NOx. Construction, non-road mobile machinery, tractors, construction vehicles, etc. Also, aircraft, particularly at takeoff, contributes to air pollution. Farming does, not just through the sort of tractor bit, but some of the dust and agricultural blow-off in terms of generating PM10 and PM2.5. Solid fuel heating, the wood-fired stoves I've kind of covered. And then there's odd things this time of year which obviously crop up, bonfires and fireworks. So on November the 5th and the morning of November the 6th, air quality is not as good as it used to be, although nowadays it tends to be anything from October the 20th through until January the 2nd, if you live down my way. And without wanting to pick on North West Leicestershire, but using that as a worked example, if you think about what North West Leicestershire have got, by the time you've got the motorway network, you've got areas of agriculture, you've got industry and quarrying, and you've got East Midlands Airport, you could argue actually, by no real fault with North West Leicestershire, they've got a bit of everything in there, which might go some way to explaining their 5.9%. Stuck in a couple of graphs. These were in the annual report from 2 years ago, that kind of broad brush. That one doesn't come out well. So blue, this is particulate matter 10 emissions. Blue is relatively good, and orange and reds are relatively bad. Now, you might just be able to make out it resembles nothing more really than a map of trunk roads. So you can follow the M1 up, particularly around junction 21 and up through junction 24. The M69 is there, the A42 and the M42 is there, and you can see the A46 as well. Equally, though, from memory, if you look towards the east of the county, things maybe aren't as good as you would expect. And again, I would expect that primarily to be agricultural blow-off, dust blow-off. And then if you look at northwest Estuary around junction 24 and into Colville, you know, it's more than just more than just the road network. And I think you're getting into issues there around quarrying and the dust from quarrying. Nitrogen oxide, which is more closely related to vehicles like PM10, but even more closely resembles the trunk road map. Doesn't quite show up, but again, you know, it's what you'd expect if you think about where traffic tends to accumulate. Just to so that was kind of the briefing and the first part. So we're going to flip that slide and come back to it. So the government published its clean air strategy not so long ago, which was the subject of the Environment and Transport Scrutiny Committee report. It talks about taking action in a number of areas, understanding the problem, protecting the nation's health, protecting the environment, etc., etc. From that point of view, I suppose today, from my point of view, is a local response to the first bit, and I suppose where we've been at the last 2 years is sharing what data we've got around what are the pollutants, where do they come from, how bad is the problem. We do need to move into action, and that takes me back to that. Currently, that clean air strategy, there was obviously some additional powers that were beginning to be talked around in terms of reducing, phasing out of real fires. Was one of the things that from memory sprang to mind that Michael Gove announced. I do struggle to sort of work out how different that is than the existing Clean Air Act 1956 in terms of what local councils could do around that. But really, I suppose we're at a position at the moment where most of the powers that are there are around the existing Clean Air Act, which is more A, the responsibility of districts, and B, geared towards travel because it's around air quality management areas. The powers that I've got, or district council's got, or the county council have got to take action around industry, agriculture, and the rest of it tend to be limited. And I guess if you think about industrial processes, it's more about the proper regulation of permitting. So, you know, if factories have got stacks and they're blowing chimneys up, we do just need to make certain that they, that they're scrubbed and filtered and complying with their regulation. But so at the moment, there is a limit to the amount of statutory powers we've got to take action, but that's not to say that there isn't a will in the way through things like the Council's Environment Strategy, which again E&T Scrutiny were considering, which would aim to pull together that multi-agency work to take steps to reduce pollution. So again, a little bit like physical activity, I've not done justice to the amount of work there is going on through air pollution, particularly around travel, but to some extent it is early days in terms of taking a broad brush approach to all the sources of pollution that we would identify.
Very much, Mike. I mean, a lot of the pictures and graphs you got there are about a couple of years ago, aren't they? Since before Harbour District Council shoved a real-time air quality meter for measuring nitrogen dioxide on the A6 in Kibworth. So it'd be interesting to see what those look like later. 'Cause even on the nitrogen dioxide one, you could see a glimmer of where the A6 was. I suspect that would now be stronger. But it is interesting. I think the point really is that it's data collection, and that without knowing what's going on, but obviously there's some information there that clearly is now coming forward. I mean, they have these little tubes they use for measuring, which they then send off to the lab, and it comes back and tells them how much nitrogen dioxide and so on's been going through the tube over the last month. And we've now got, I think, over 15 now down the A6 through the middle of Kibworth, as well as our real-time monitor. And they've also now invested Harbour having a portable bit of kit that they can put onto lampposts once highways let them put it on the street lamps because it might fall over. Is a machine that now measures particulate matter and sulfur dioxide and some of the others as well, which the university have been working on. So it's getting that data, and once you get the data, you begin to do things with it. But it's just getting that data.
Yeah, you're quite right. I just put that one up because you can, although it's a bit faint, you can see the A6 just in the kind of lighter colour as it's running out, can't you? Yeah.
Is the information behind that for specific areas available?
Yes, so from memory, if you go on the DEFRA website, so that map is, or every pixel is a kilometre square, something like that.
So have you got the national one?
Yeah, so, so again, if you jump on that one, it would give you the set. Basically, I've lifted the map from the national website.
Which website's that?
I think it's the
business.
There's a DEFRA website. I forget the website address. But if you Google DEFRA and air quality map, it would take you there, and can put that in the minutes as we go. That's kilometre square, and then obviously air quality management areas will give you a bit more point-specific sorts around air quality, which district councils would have.
I think it'd be remiss of me being the county councillor for Braunston Division not to highlight just how bad it looks around Foss Park. It's, I think, we obviously identify North West as being a big cluster of lots of pollution, but clearly that Junction 21, Foss Park area on this map seems pretty significant. So it'll be interesting how that goes down, but I'm assuming it's going to be that junction in particular that's the problem. I suppose with a lot of this, it's what can we strategically do about some of this, and clearly linking to the project before in terms of behaviour change and how we change behaviour is obviously part of the solution. But how do we, as an authority, start improving our air quality within our responsibility? And I'm sort of looking to you to tell me because I don't know.
There's all sorts, isn't it? I mean, there's all sorts of things either under the banner of climate change, meeting the council's commitment which are made to being carbon neutral, the climate emergency declaration, or active travel, or indeed through planning. So, getting ahead of what the plan on the page would look like, but what can we do? Well, we can take steps ourselves because we're still a major employer. So if you think about the things that we've started doing, E&T have invested in an electric pool car, which others can use to get to meetings. We encourage people to use the e-bikes to get down to their city in particular and back rather than take the car. Trying to get people to leave the car, park and ride, park and stride from Glenfield. There's a number of things we can do about reducing car use within our own staff. There is, coming back to the active travel bit, how do we make it easier for people to take sustainable forms of transport and not take the car? And again, we've got a key role, not just in terms of leadership, but our own assets, and Lutterworth would be a good example. What else can we do? There is the active design stuff as well, which is if you can't eliminate pollution, then at least you can mitigate the worst effects of it. So we talked about cycle paths in relation to that. Of course, you don't have to go too far. The drop-off in terms of vehicle emissions and distance from it does kind of drop off fairly quickly. So if you're able to move away from having painted white lines on a road and try and get cyclists and pedestrians on a dedicated footpath the other side of a tree line, immediately you're putting up some kind of barrier called a tree, and you're getting 2, 3, 4, 5 metres away from the point of source of pollution. The point I made earlier on about, sometimes you're worse being stuck behind the exhaust pipe in front of you. Even if you think you're within a nice, safe environment called your car, you're probably getting more of a lungful than if you were stood 2, 3, 4 metres to the side, just because of the way the pollution kind of goes across. So there is a number of things that, as a county council, both directly with our workforce, directly because of the things that we own and the things that we do, and working with others, that would affect active travel, active environment, active design. You could almost use the annual report around physical activity as a bit of a guide and say, can we apply those same principles to air quality and clean air?
Yeah, I think from a sort of strategic authority point of view, it's actually how do we get more trees? How do we encourage through maybe our highways consultation for planning applications to have, well, this is what legally we should be doing with highways, but actually can we add these as well? I mentioned in the pre-meet before, we've in just outside the division, we're having a rebuild of the Aldi supermarket at some point in Thorpe Astley. But actually, to fight to get a few extra trees and a walkway across the main entrance was actually really hard work. Had highways had put that in, it would have made it a lot easier. But maybe we should be looking at carbon offsetting for big build, that kind of thing. That there is certainly green space where they could do some more carbon offset. I think particularly the biggest issue with that facility is taking solar panels off the roof. and I don't know what they're going to do to replace it in the new bill. We don't, we're not saying through art and design this is what we have to do. So, and I don't know whether or not we could learn from other countries, because there's certainly, I think it's in Japan where they've got clads on big roads, infrastructure. They actually clad them in green mesh, so plants can grow up the clads, which looks nicer, definitely. I mean, clearly maybe not the best for concrete, but we could do some of those things.
Yes, we could. Carbon offsetting is an interesting one, isn't it? I mean, it's almost a hierarchy of what one would want to do around climate change and air quality. And certainly would say the first thing you'd want to do is to actually just take the carbon out in the first place. Next best thing is then how do you offset, how do you mitigate the impact of it? So it has a role to play. I think it would be sort of second on the hierarchy of what I'd want to do, and the first would be take it out in the first place.
David.
Chairman, I'm a bit disturbed that the Great Central Railway has been picked out as a pollutant. So I suppose I'm to blame really then if that's the case, because I've spent so much of my life trying to preserve these wonderful assets, and I've never felt better than breathing in the coal, the coke, the hot oil, and all the rest of it. So it hasn't done me any harm. Well, I don't. Anyway, there we go. Anyway, so, but could we? Is it possible to take the previous report and this report and send on some action points for the rest of the authority and district colleagues to follow? This is so serious that I think we can't just sort of read it and say, well, oh dear, and then leave it. We ought to be making some recommendations in some direction, couldn't we? And I think it also, I hate to raise it, but the A46 Expressway, which you understand where I'm going with this one. I do. Well, I don't need to say any more, but you can see what that will actually produce, a brown ring all the way around the south and east, which I think we ought to sort of feed that into that process as well. Can I leave that with you, Chairman, to work out how we
It has struck me that the same thing, only I think it's now become a matter of environmental air quality issues versus housing. That seems now to be the battleground. But yeah, I really do think it's beginning to prove, I think, quite clearly, especially from the diagrams, that where there is major traffic routes, you do get air pollution. And at the moment, unless we reduce the traffic and air pollution, I don't see that's going to change. I mean, a lot of people talk about electric cars, but it's we're a long way away from that at the moment. So we have, I think, 4% now go through the A6 in Kibworth, so it's rising. But,
so a few thoughts from me. We'll deal with the trains. Yeah, the Great Central Railway does, unfortunately. The other bit that springs to mind, you remember Nottingham City Council, I think, when they were talking about the Midland Main Line electrification, did raise the issue about diesel trains idling at Nottingham Station, which is probably more of a source of pollution for them than it was for Great Central Railway. So railways do contribute, which is why if we had an electric line, it'd be great. In terms of comments from Scrutiny, as I say, what stemmed from the E&T Scrutiny Committee report and the Clean Air one was this commitment to put together some form. I don't want to call it a strategy. I think I'd rather call it a plan on a page, because I want to move from just having a strategy into getting into work. It would probably be useful to reflect the comments initially of Scrutiny now, so we can feed that into that work. And again, depending on the governance process we need to do with that one, it'd be nice to bring that one back to Scrutiny so you can see what the plan looks like. And Expressway I won't comment on, if you don't mind.
Thank you very much. Yes. No, indeed. I mean, I said it. Yeah. It happens automatically. Yeah. Well, it's happening anyway, because Mike's going to be preparing a paper for Cabinet.
It's already in train, but again, it would be worthwhile just to tie it in with health scrutiny as well.
So, I mean, this was really only a sort of a brief introduction to the issue, which I raised at an agenda planning thing some time ago. And Mike very kindly has produced this today, which has obviously stimulated a bit of discussion. Thank you very much, everybody. Anyone else? No? Yes, Amanda, yes.
Can I just ask a health question? I mean, in terms of the air quality particulate matter, we obviously have the data to say that air pollution contributes 40,000 premature deaths per annum. Is there any way that we could overlay over the top things like COPD and asthma rates, and does that correlate over these maps? Because that gives you the biggest, visual impact of what air quality does. I mean, I do know that Blaby District Council had a paper a few years ago that looked at COPD rates in Blaby, and it's not massively dissimilar to where the orangey bits are on here. So it'd be really interesting to actually overlay, if we've got it, health data over the top of air quality.
So what I'm thinking is that the data that's now more readily available to me would be your kind of mortality data and hospital admission data from COPD, cancer, respiratory disease. That wouldn't be readily available on the same geography, so I can't necessarily do the same pixel 1 kilometre square stuff, because that, I think from memory, I used to be able to do it in health service data. I can't now do it now in local authority because of the level of data that I can get hold of readily. But I can put together district level data with an air quality map. You then get into a debate about what's driving it, because of course, at that level we're in districts, it would be more than just air quality, and you get into issues around deprivation, affluence, social class, etc., etc. But as a rough, it's probably worthwhile playing around with and seeing what it looks like, and then seeing if it tells us anything that we don't know already. But you would expect there to be a clear link between hospital admission data on a Leicestershire level for things like cardiovascular disease and respiratory and COPD, whatever, and air quality. Now, whether that trumps other causes, see what I mean? You then get into kind of if you've got 5.3% is attributable to air quality, it does mean there's 94.5% other stuff going on as well. So you just need to pull apart what that means. But
I've just remembered actually looking at that picture. Because that's nitrogen oxide, and the highest figure I think on the right of the bar chart, the reddest figure I think is 44.3. Just to put that in some context, in 2018 on the A6 in Kibworth, we were hitting monthly figures of over 50. And that just shows the difference between, that was 2017, so give it another couple of years, and it just shows you when you do get some heavy traffic, and particularly small vans and anything that's producing nasty, noxious fumes, it goes up that quickly. Yeah. But we are looking at it still. Okay, thanks very much. Thank you very much, everybody. Our next meeting of this particular committee is scheduled to take place on the 15th of January at 2 o'clock. That is 2020, by the way, at 2 o'clock. Thank you very much for attending.